All right. Today, hopefully, we'll be able to finish at least 50 questions, including rationalizations and a little bit of discussions, particularly on the following topics. These are the topics that I prepared today. Some questions, like, for instance, schizophrenia and psychosis. I prepared 20 questions. Then we have to rationalize it. Mood disorders, including depression, at least I prepared 10 questions. Depressive disorders, also 10 questions. And personality disorders, prepared 10 questions. So I think our discussion today would be around more or less 1.5 or 2 hours. Okay, so I'm going to start with, hopefully yesterday you were able to refresh your memory about the foundations or fundamentals of psychiatric nursing. Now we'll start with question number 1. The flow of our discussions will be like this. Now I'm going to plus questions, then we try to read. Then after that, we're going to have a little discussions. At some point, I am going to make a little bit of illustrations about specific points that I believe it's very important or will be very important in your understanding of psychiatric cases. So let's proceed with number 1. I invite you to read with me as I'm going to read it here. So I will start with question number 1. Okay, here we go. Here we go. So a paranoid client presents with bizarre behaviors, neologisms, and thought insertion, which nursing action should be prioritized to maintain this client's safety. Okay, so the choices will be number 1, or letter A, assess for medication non-compliance. Letter B, note escalating behaviors and intervene immediately. Letter C, interpret attempts at communication. And letter D, assess triggers for bizarre, inappropriate behaviors. I repeat the question. So let's try to have at least 1 minute to analyze the question and then come out with the answer. I read the question twice, so that will be the flow. I repeat the question. A paranoid client presents with bizarre behaviors, neologisms, and thought insertion, which nursing action should be prioritized to maintain this client's safety. A, assess for medication non-compliance. B, note escalating behaviors and intervene immediately. C, interpret attempts at communication. And D, assess triggers for bizarre, inappropriate behaviors. Analyze the questions, then come out with your answer. Okay? Who would like to answer? Anybody? What is our question here? What are the things that we have to remember here? So the question is actually pertaining to client safety. Always remember, yesterday, I mentioned to you that the first thing that we have to prioritize whenever we are going to take care of patient with psychiatric disorders would be the safety of the patient and the safety of other people, including nurses, other patients, nurses, and family members. So what can you derive from the questions? What is your answer here? Okay, so let's see. The answer is, I'm stuck. B, no? Note escalating behaviors and intervene immediately. Okay, so remember, the patient is paranoid already, suspicious, highly protective of his privacy and of himself. He is suspicious about other people. He is thinking that other people may harm him. And one thing more that is actually very notable here is that he got bizarre behaviors that these are the behaviors that out of normal right? He would be shouting, and we can derive from the question that the patient actually has lost thoughts. Particularly, it is mentioned here also neologism. Neologism is a very bizarre behavior wherein the patient is inventing his word that he alone can understand. We cannot even understand it. Sometimes he murmurs, sometimes he mentions word that would not be understood by anyone. So basically, the patient is really a little bit agitated in this case, unreasonable, and chances are he could be violent. So the first thing that we have to look into will be client safety and how are we going to do that, right? So we are going to look into the escalation of behaviors and escalate it and intervene immediately. Okay, so the nurse should note escalating behaviors and intervene immediately to maintain client safety and the safety of others. No, early intervention may prevent an aggressive response and keep the client and others safety. Ano ang gagawin natin usually dito? So makikita na natin ng pasyente ay bizarre. Nag-umpisa ng magwala, nag-umpisa ng sumigaw. So sometimes we are bringing them to the HTU, we isolate them, and if there is a standing order on giving sedative, we give. Yun ang ating intervention for this case. No? Usually there is a standing order wherein the patient may be given sedative immediately. So that's a form of restraint that we usually use in the hospital. No? That's chemical restraint. What is the client need as we consider? The safe and effective care environment or the management of care. Always, we are going to think about patient safety and the safety of others. Yun ang una nating pag-iisipin when we are going to encounter any psychiatric case outside the hospital or in the hospital. All right, we proceed with number 2. A client diagnosed with schizoaffective disorder, this is one of psychosis, is admitted for social skills training. Which information should be taught by the nurse? So I repeat the question. A client is diagnosed with schizoaffective disorder, is admitted for social skills training. Which information should be taught by the nurse? Now remember, when we are going to take care of patients who are actually in the hospital, there are several things that we are actually doing. We call it psychotherapeutic interventions, including social training. So this will be the responsibility of the nurse. And of course, with the cooperation or in coordination with social workers or psychologists who are on duty during the time. So these are the choices. The side effects of medications. We assume that the patient is already taking medications. Deep breathing techniques to decrease stress. How to make eye contact when communicating. How to be a leader. Now remember, as I mentioned to you yesterday also on the process of test taking, we have to go on the process of elimination also. Remember, there is one choice in the different choices, the multiple items are pertaining to communication. So we can immediately look into that as our possible answer. So we have to think critically as we go and look into the different questions that are on us. And always remember this, when we are answering questions in the board examination, there could be sometimes questions would not be definitely answered in the choices given to us. So what we will do is to derive questions that are nearest possible answer or derive answers to the nearest possible answers that are actually posed on us. So in this case, what could be our possible answer for question number 2? It is C, right? Eye contact So sometimes patients who do have schizoaffective are withdrawn. They do not socialize. They are isolated. They would like to be alone. So it will be very difficult, and it is going to be a challenge also to make them talk much more, to make an eye contact. They're standing usually on the floor, nothing else. They are standing anywhere else other than the person in front of them. So the first thing that we can actually do as nurse to make it sure that the patient will initiate eye contact. It will be a challenge. Taking care of psychiatric patient is always a challenge. It's not just like walking in the park. So it is, we face a lot of challenges every single day that we deal with the patients, no? So the answer is C. The nurse should plan to teach the client how to make eye contact when communicating. This is actually very important. In any cases also, if the patient is diagnosed with mood disorder the same way, social skills such as making eye contact can assist clients in communicating needs and maintaining connectedness. Our dream as nurses, when we are working in the psychiatric ward, is to communicate. People who have been there for a long time may not communicate with you. There is selected mutedness. They choose to be muted, they choose to be isolated, they choose not to talk. So it is inherent in their sickness. So we have to understand that. So every single day, we have to struggle to do this. And every single day, we really would like them to communicate with us. And the best way of communicating with us is to train their social skills, particularly on looking at us in the eye or making eye contact. The client needs, we look into psychosocial integrity. Now, as we have discussed yesterday, when we are going to evaluate a psychiatric case, we look into 3 dimensions. The first dimension is biological or physiological. The second dimension is psychological. And the third dimension is sociocultural. So both ways, we have to look into, in terms of social isolation and inability to talk, we have to make it sure that the patient will actually be addressed. The needs of the patient will be addressed in terms of the psychological needs and in terms of the social needs, including sociocultural needs. That's the reason why we have to address this. The problem are derived from here, obviously, really. So whenever we're going to make diagnosis, we have to look at these 3 dimensions. And whenever we're going to do nursing intervention, we're going to look at these dimensions also. That's the secret of surviving psychiatric nursing, you know. So we have to look on the 3 dimensions as always. Physiological and biological. When we address psychopharmacology, when we address already the physiological needs, then psychological, and at the same time, sociocultural. Here, the client needs that we have to bear in mind is psychosocial integrity, the psychosocial needs of the patient. That is, to be connected with other human beings, to be connected with other people. So always remember that. Tandaan natin yan. No? It's very important. Titingnan palagi natin ang 3 dimension ng kanilang kanilang sakit sa hospital. Question number 3. You may butt in if you have some questions, no? Or if you can actually add some of the inputs that may be lacking when I'm discussing. I'm compressing as much as possible the questions and the knowledge that you will learn out of this today. So question number 3. A 16-year-old client is diagnosed with schizophrenia, experiences command hallucinations to harm others. So remember, we are encountering different psychiatric terms. The first term that we encounter in question number 2 is neologism. That is invention of words by the patient, that the meaning is understood by the patient only. What about hallucination? hallucination is a perceptual disorder wherein the patient actually perceives something that are not there. As I mentioned to you yesterday, the basis will be on 5 senses. That's why we classify different types of hallucination according to our 5 senses. The most common that we have among schizophrenic patients would be the basic two: visual hallucination, auditory hallucination. Sometimes there is olfactory, there is gustatory also hallucinations, and sometimes in severe cases they have tactile hallucinations. That's no. So here the client's parents ask the nurse, where do the voices come from? Which is the appropriate nursing reply? How are you going to answer that as a nurse? The parents of the patient is actually asking. Now, usually, ang ginagawa natin dito, we don't reinforce the false belief that the patient may actually have. But dito, hindi ang pasyenteng nagtatanong, kundi ang magulang. So ano ang dapat nating isagot? A, your child has a chemical imbalance of the brain which leads to altered thoughts. B, your child's hallucinations are caused by medication and interactions. C, your child has too little serotonin in the brain, causing delusions and hallucinations. Or D, your child's abnormal hormonal changes have precipitated auditory hallucinations. And the way we explain, it's actually using medical terms, and sometimes the patient may not understand. But in any way, what could be our answer here? Is there any chemical imbalance or hallucination with child's caused by medication interaction? Or C, your child has too little serotonin in the brain, causing delusions? Or D, your child's abnormal hormonal changes have precipitated auditory hallucinations. So let's pause for a while, analyze the question, and come up with our answers. Okay, the answer is A. What is A? Your child has a chemical imbalance of the brain which leads to altered thoughts. Now remember, our behavior is caused by our perceptions that are originating from the brain. And our perceptions are caused by the interaction of chemicals. Remember, we convert, remember in your anatomy, you learned that, no? All the triggers are actually picked up by our sense organs, then it will be interpreted in the brain. And in the brain, there are chemicals that are interacting, like I mentioned to you. We call this as neuropeptides, or neurochemicals. Very basic example is serotonin. That is actually has something to do with depression. We have dopamine. We have acetylcholine. We have norepinephrine, which is actually in the brain also. You see? So obviously, we can actually answer that way. So if the parent question more, then we can actually explain about this. Okay? So usually, hallucinations could be caused by chemical imbalance that are actually happening in the brain. That's the reason why we cannot treat hallucinations using psychotherapy. We can treat hallucinations by giving them antipsychotic medicines like chlorpromazine. We'll discuss about that. There are questions that I asked about medications appropriate for patients with schizophrenia. Okay? So we give medications. And what do these medications target? Usually the brain. So what is actually the client's need here? It is health promotion and maintenance based on biological factors. Biological or physiological factor. That means to say it has something to do with the anatomy of the patients, no? So the answer is A, explanation. The nurse should explain that the chemical imbalance of the brain leads to altered thought processes. Hallucinations or false sensory perceptions may occur in all 5 senses. I explained to you about this yesterday. So what is what is the difference between illusions and hallucinations. Now, tandaan natin, ang illusion, mayroong sense objects. May object, pero the way we perceive that object is different, totally different. Pero ang hallucinations, wala. Halimbawa, nakakakita ng tao, so walang object na nakikita, pero may nakikita tayo. So that is the meaning of hallucinations. That's the reason why we call it false sensory perceptions. That may occur in all 5 senses. Again, these different types of hallucinations are visual, auditory, olfactory, gustatory, and tactile. But the most common among patients that we can actually observe from would be visual and auditory. Okay? The client who hears voices is experiencing an auditory hallucination, as I mentioned to you earlier. Okay? Now, how are we going to deal with this? Do not reinforce. Okay? Do not reinforce the patient when you are dealing with the patient. Like, for instance, when the patient is already complaining, there are 3 people who are threatening me. The other in front. So what are you going to do? You see? Oh, I see 3 people also. That's, hindi pwede natin gawin yun. Oh, mayroon din ako nakikitang 3 tao sa harap mo. Oh, nakahawak ng kutsilyo at nagtatangkang saksakin ka. You cannot do that. We will not reinforce the false sensory belief of the patient. Okay? So I will discuss to you more about that as we go on. Question number 4. Parents ask a nurse how they should reply when their child, diagnosed with schizophrenia, tells them that voices command him to harm others. This is very common. Okay? Voices command him to harm others. Will is appropriate nursing reply? Is it A, tell him to stop discussing the voices? Is it B, ignore what he is saying while attempting to discover the underlying cause? C, focus on the feelings generated by the hallucinations and present reality? So more or less, you know the answer already. Or D, present object evidence that the voices are actually not real. Now remember this also. Do not reinforce, do not contradict. Do not reinforce, do not contradict. That's the best thing that you always bear in mind. Okay? If you're going to reinforce, you're reinforcing false belief system. If you are contradicting, there is the danger that you are going to quarrel with the patient, and that's not good. All right, so what is our answer? The answer is letter C, as I mentioned to you earlier. Okay? What is letter C? Focus on the feelings generated by the hallucinations. And remember, this is actually very crucial. You are not contradicting the patient, but you are presenting reality. How are you going to do that? Sige nga. Paano natin? So, ang pasyente ay na-diagnose with schizophrenia. Then, there is a claim that the voice is commanding him to harm others. Anong sasabihin natin? No? Ano ang gagawin natin sa pasyente? If the patient is already there, rightfully. Okay? So, sometimes we are going to deal with the patient like this. Okay? Alam ko na ang pakiramdam mo ay unpleasant or natatakot ka, pero wala naman ako nakikitang tao na gustong manakit sa'yo. So in that way, you are presenting reality. Wala naman ako nakikitang tao na manakit sa'yo. You see? So you do not see any other person who may harm the patient. So you are presenting reality in that case kasi ikaw mismo ay hindi nakakita. It's not contradicting the patient, but this is the difference. You are not contradicting the patient, but you are just presenting reality. All right? So that's how it works. So what is actually the things that is addressed here? The psychosocial integrity. Here is the explanation. The most appropriate response by the nurse is to instruct parents to focus on the feelings generated by the hallucinations and present reality. The parents should maintain an attitude of acceptance to encourage communication, but should not reinforce the hallucination by exploring details of content. You see? So you should not reinforce hallucination, but sometimes we are actually tempted to do that. You should not do that. You do not even ask them to describe who or what type of people that they are seeing. Or else, if you're going to do that, you are reinforcing hallucination. Like, for instance, the patient is already there on the defense. Sometimes when they are very paranoid, so they are very defensive to the extent that they are trying to protect themselves and ready to harm others. So, hindi natin pwedeng tanong ng ganito, ano? Anong nakikita mo? You see? Oh, ganyan. I-describe mo ako ano nakikita mo. We cannot actually do that. You see? Because asking them to describe what they see is reinforcing their false belief, as I mentioned to you earlier. So it is very inappropriate that you present logical arguments to persuade the client to accept the hallucinations as not real. In that way, we will not also contradict the patient. We do not reinforce, we do not contradict. Always bear that in mind when we take care of patients with hallucinations. So what do we address on the client needs? Psychosocial integrity. Moving on with question number 5. A nurse is assessing a client diagnosed with schizophrenia. The nurse asks the client, do you receive special messages from certain sources, such as television or radio? Which potential symptom of this disorder is the nurse assessing? Okay? So, ano ang ating choices? Thought insertion. B, paranoia. C, magical thinking. D, delusions of reference. Or sa pagtuturo ng mga teachers sa Pilipinas, ideas of reference. The same, no? Repeat the question. A nurse is assessing a client diagnosed with schizophrenia. The nurse asks the client, do you receive special messages from certain sources, such as the television or radio? Which potential symptom of this disorder is the nurse assessing? Is it thought insertion? Is it paranoia? Magical thinking? Delusions of reference? You see? There are 2 possible answers here. Okay? Anong ibig sabihin nito? Dapat titingnan natin ang mga choices. Is it thought insertion? Alam mo yung thought insertion? Ganito yung definition nun. Parang yung pasyente, iniisip niya na iniisip niya, pwede siya mag-insert ng iniisip mo. Ganon yun. Number 2, paranoia. You know this, feeling of suspiciousness. Magical thinking that, so they are out of touch with reality, they are outside reality. So basically, that would not be the answer. Or is it ideas of reference? Or delusion of reference? That means to say, lahat ng mga tao na nakapalibot sa kanya, siya ang pinag-uusapan. It has something to do with themselves. Yun ang ibig sabihin nun. Halimbawa, ang pasyente, nakita kayong nag-uusap sa tabi, although iba ang pinapag-usapan ninyo, so ang mangyari niya, nang iniisip ng pasyente, siya ang pinag-uusapan ninyo. Ganon din sa TB. So the possible answers could be thought insertion or delusions of reference. But based on your analysis, what could be the answer in question number 5? So let us try to rationalize the answer or your answers. Always remember, in picking up your answer, you always choose the best possible answer. Correct answer may not be there, but the best possible answer may be chosen. There is no choice to debate. No, sometimes we are debating with the question. We cannot do that. No, we need to choose the possible answer. The next, yes. And I think my computer is stuck. You're still following me? Okay. I have the answers here, I think. No. I didn't place the answers here. All right. What is actually the answer here in number 5? It is ideas of reference or delusions of reference. Yung feeling niya, siya ang pinapag-usapan. Right? So thought insertion is the belief system of the patient na siya ang nagbibigay ng instruction. So pag nakuha niyo yung definition ng thought insertion, maaring ma-confuse kayo dito. So it's necessary that you have to think about what could be the possible answer in this case. The nearest possible answer is your ideas of reference or delusion of reference. Okay? So let us try to look into the definition of schizophrenia as I inserted here. Because I already finished some questions. There will be some more questions about schizophrenia as I mentioned to you earlier. As I said, I prepared 20 questions on schizophrenia. I would like that you have a good understanding of what schizophrenia is. Now remember, 85% who are admitted in mental hospital or in psychiatric hospitals are schizophrenia cases. They are long-term, no? The moment that we are admitting them, we're going to treat them for a long time. Okay? So as I said again, the moment that we treat them, we cannot or we are expected not to treat them in such a way that they can assume the pre-morbid state. That means to say, hindi na talaga sila gagaling kailanman. And their cases will become chronic once in a while. They're treated, they go out, then they come out with the symptoms, they're treated, then they go out, then the symptoms are actually coming all the way, all the time. Okay? So titingnan natin ang definition by so far and types of schizophrenia that I have so that may imagine nyo kung ano ang mga tinatanggap natin sa hospital in cases of schizophrenia patients, no? So by definition, what schizophrenia is, no? Schizophrenia represents the most severe form of psychotic disorders. The moment that you are going to be diagnosed with this, wala na talagang pag-asang gumaling. Okay? Wala na talagang pag-asang bumalik sa kanilang pre-morbid state. Tandaan natin yan. It will always come back. Symptoms will always come back. And the best thing that we can do as nurses will be to make it sure that they can be very functional with their daily lives, and they can control the different symptoms that are presented to them. Like in the case of hallucination, they should know that. They should know when they are hallucinating so that they can control it. They should know when they are delusional so that they can control it. Self-awareness, as we call it, no? So the other psychotic disorders also show some of the features seen in the schizophrenia but differ in intensity, duration, and functional impairment. And ito ang napaka-importante, pwede silang gumaling. So tandaan natin yan, schizophrenia is worst case under psychosis. Pero marami pa rin sakit under psychosis na presenting the form or signs and symptoms of schizophrenia. That I'm going to present to you later on. So, ang mga cases na to ay pwedeng gumaling. Particularly, they can become what they were before the pre-morbid state. So, moving on. Ito ang different types of schizophrenia that we may actually have. There are 5 of them. As I keep on telling you yesterday. Paranoid type. Ito yung mga delikado. Ito yung mga violente palagi. Okay? They are always having auditory hallucinations. People are threatening them or they are being commanded to harm others. So that's it. Maraming boses na nagde-dictate sa kanila kung anong dapat nilang gawin. Particularly, yung dictation nila usually is very negative, commanding them to do something. No? So what else? They have preoccupation with one or more delusions, usually of persecutory type. They are thinking that they are always persecuted. They're always thinking that there are people or people around them are there to harm them. That's usually what they are thinking. You see? Number 3, they appear hostile or angry because that's the defense mechanism. That's the defensive mode. They are always on the defense because they are always thinking that other people are there to harm them. They lost confidence with other people. So that's the reason why they are isolating themselves also. They do not want to see other people. That's one thing. Okay? None of the following are present. So wala dito. Sila ay violente. Sila ay nagsisigaw. Sila ay very protective about themselves, about their own privacy. So hindi natin makikita sa kanila ang katatonia. Hindi natin makikita sa kanila ang plot affect. So that's why we classify them under paranoid type. They are not disorganized. They do not have any disorganized speech or behavior. No? So they do not have waxy flexibility. They do not have catatonia. That's the difference of this. Okay? That is the difference between paranoid type and other types of schizophrenia with the following signs and symptoms. So ito palagi silang violente. So we are always on the lookout with that. Maraming pasyenteng paranoid type, no? Okay? So they are very dangerous in any way. So the next one is catatonic, no? Catatonic type. So they are not violent. They're always in the state of stupor, yeah, state of daze or unconsciousness or extreme motor agitation. They assume certain position for a very long period of time. Magtaas sila ng kamay within the whole day. Hindi sila napapagod. So they have excessive negativism. They assume one position for a single day. Sometimes they don't eat. So, pag ang isang pasyente ay andun na nakaupo sa tabi, magdamag, pwede makaupo sa tabi nun. So, that's how it is. That's the meaning of catatonic stupor, catatonic time. Or sometimes they are very slow to move. So that's how it looks like, no? They have inappropriate or bizarre body posture. Most of the time. Sometimes they are slouch. Sometimes they are assuming fetal position, among others. They do also echolalia and ecopraxia. Anong difference ng echolalia at ecopraxia? Yung echolalia, yung iniiko yung boses mo. Yung iniiko yung words na sinasabi mo. Halimbawa, tanongin mo, anong pangalan mo? They will repeat what you said. Anong pangalan mo? Saan ka pupunta? They will repeat, saan ka pupunta? That's the meaning of echolalia. Yung ecopraxia naman, yun ang pag-repeat ng movements ng isang tao. Pag nagtaas ka ng kamay, tataas din sila ng kamay. Pag facing left ka, mag-face left din sila. That's how it works. So they follow every movement that you actually do. Ganun yun. Okay? So you should know the difference between catatonic type and paranoid type. Yung paranoid type, very violent, very agitated, at on the lookout, very defensive. Sumisigaw yan. Maaring masaktan nila ang sarili nila or masaktan nila ang ibang tao. Residual type. Ito yung pangatlo, no? The absence of prominent psychotic symptoms. Ano ba ang tinatawag nating prominent signs and symptoms ng schizophrenia? Very basic. Delusion and hallucination. Pag nakita natin na ang tao ay may delusion and hallucination, maaari nating sabihin, yung pasyente ay may schizophrenia. Pero, ang delusion at saka hallucination may be present in other psychotic disorders or may be present in bipolar disorder. That's the reason why it's necessary for us to make differential diagnosis, no? So walang delusion, walang hallucinations. Okay? In residual type. Wala silang nakikitang tao, hindi sila nakakarinig ng iba't ibang boses, no? They are socially withdrawn, and of course, they have eccentric behaviors, no? And in any way, they have past history of one episode of schizophrenia or sometimes brief psychotic disorders. So ganun yun. Na-control na nila or wala na yung wala na yung very prominent symptomatology ng schizophrenia. Sometimes, they may be eccentric in any possible way. Yun ang tinatawag na residual type. These people are not confined in the hospital any longer. They are living with us in the society or in the community. So they are less dangerous. But of course, one way or another, they are not normal like us. No? Sometimes they are very eccentric in any way. So makikita natin yan, no? Yung mga nangungulekta kung ano-ano, ganung bagay, no? Then we have the disorganized type. Okay? They have disorganized speech. They do not have hallucination. They do not have delusion, no? They have disorganized behaviors. They have inappropriate or blunt affect. Yung emotions nila is very blunt, no? We call it flat affect, as we call it. Yeah. And then there is the last one, number 5, is undifferentiated type, none of the above. So hindi makitaan ng symptoms on the 4 types of schizophrenia. So they may have disorganized behaviors, although they have psychotic symptoms, no? Maraming mga psychotic symptoms na nakikita natin, like yung fog, marami yon. So they may display some once in a while these eccentric behaviors also. Like yung paika, they eat something that's inappropriate. So, ganun yan. So, more or less, yung mga taong grasa, nakikita natin under residual and undifferentiated. Okay? Yung mga taong nangungulekta ng bottles, tapos kinikerry nila everywhere. Right? So, yun. So they are harmless in any way. Not like in paranoid schizophrenia that they are very harmful. There is a danger that they can harm themselves and other people. Okay? So these are the symptoms of schizophrenia. 2 more slides pertaining to that, no? The positive symptoms and negative symptoms. So titingnan natin yan. So alam na natin ang 5 types of schizophrenia. So titingnan natin at we need to understand that different signs and symptoms, no? The positive symptoms and negative symptoms. Ano bang ibig sabihin nito? So, ang positive symptoms ay mga simptomas or any change in behavior or thoughts. Remember, pag-iisip, such as hallucinations and delusions. While negative symptoms, these are the symptoms that may actually come after, right? After the positive symptoms, no? They may appear to withdraw from the world around them, take no interest in everyday social interactions. They have social isolations, and sometimes they appear emotionless and flat. Okay? These are some of the positive symptoms that we have, as I mentioned to you. Pag makita natin ito, tumpak, malamang ang pasyente ay may schizophrenia na. Delusions, hallucinations, strange or inexplicable behavior changes, okay? Confusion or thought disorders. As I mentioned earlier, they are called positive symptoms dahil may pagbabago sa kanilang pag-uugali at pag-iisip after the individual develop schizophrenia in any way. Sometimes, pag nakita natin ang pasyente ay pupunta sa hospital, they may not actually be displaying hallucinations or delusions. Strange behaviors only or bizarre behaviors. Halimbawa, pagkain ng hindi nararapat, pag inadmit natin or halimbawa violent sila, pag punta nila sa hospital, doon na natin makikita na may hallucinations at delusions sila in any way. This could be possibly developing there. While the negative symptoms, are have something to do with the social life, no? With the way they deal with other people. Okay? So negative symptoms are named as such because they refer to thoughts and behaviors the individual had before developing schizophrenia, but has since lost. In other words, negative symptoms are key aspect or characteristics of the person that have disappeared. Yung nawala ng interest sa pagkikipagkaibigan, nawala ng interest sa buhay, nawala ng interest sa relationship, sa sex, sa pagkain, sa vocation, loss of interest in daily in things that make them happy. We call that as the anhedonia. Okay, anhedonia. We do not enjoy anymore what we were enjoying before. That may appear in your negative symptoms, right? Ito yung mga nawawala sa mga tao pagkaroon na ng pagka-diagnose na ng schizophrenia. Okay? They lack concentration, right? Not wanting to leave the house, gusto na lang nila sa bahay, and there is, of course, a change in their sleeping patterns. And then being less likely to initiate conversations, they just respond but do not initiate conversations, and they feel uncomfortable with people. They feel that there's nothing to say anyway. So they do not want to talk with other people. That's the reason why they're withdrawn. Ang negative symptoms ay nag-a-appear lamang pag ang pasyente ay malapit ng maggamot, no? That's how it is, no? So the most the most concerning symptoms that we are addressing are on the positive symptoms of schizophrenia that we have to address first, no? These are some of the form of other psychotic disorders that I was telling you a while ago. We have brief psychotic disorder. Ito ay hindi schizophrenia, pero may mga psychotic symptoms like delusions, like hallucinations, like disorganized thinking and disorganized behavior, and sometimes they have catatonic signs. But we do not classify them as schizophrenia. It may be short-lived. It may be a week only. That's the reason why, again, kahapon, sinabi ko sa inyo na ang pag-diagnose sa pasyente, pag-admit natin sa hospital, we need at least 3 weeks, tatlong linggo, 21 days to observe patients. Pag brief psychotic disorder, mawawala na ang symptoms within 1 week. So, that is not obviously schizophrenia, but our treatment of patient with brief psychotic disorder is similar to schizophrenia. We treat them according to the presenting symptoms. Like if they have hallucinations, we treat hallucinations. We give antipsychotic medicine. In 1 week, mawawala na yung kanilang symptoms. Pwede na silang umuwi sa kanilang bahay. That's the difference between brief psychotic disorder and schizophrenia. Schizophrenia, pag mayroon ng pasyente, in 3 weeks time, mayroon yan, tuloy-tuloy. There is schizophreniform disorder also. They have the essential features of schizophrenia, all right? But this is also not schizophrenia in any way. Then schizoaffective disorder. Ano ito? There is a presence of mood disorder. Remember, symptoms of schizophrenia may be found among patients with mood disorder. Like they may be manic once in a while. Manic means sometimes they are euphoric. They have depressive or mixed episode also. And the characteristic features of schizophrenia are there simultaneously for a considerable period of their illnesses. Like nagkakaroon din ng presence ng hallucinations and delusions. So magkakapatong-patong na yan. So almost similar ang kanilang symptomatology. So pare-parehas yan, schizophrenia, brief psychotic disorder, bipolar disorder. So that's why we, as psychiatric nurses also, including the psychiatrists and clinical psychologists, need to make differential diagnosis. That's the reason why, as nurse, it's our duty to closely monitor, closely record all the observations that we have with the patient. very important yan para sa pag-diagnose accurately about our patient. Then, there is delusional disorder. Lahat ng mga symptoms ng schizophrenia ay wala except delusion. No? So, there is only one presence of non-bizarre delusions. But they do not have hallucination. They do not have some sort of disorganized thinking patterns. They may not have catatonia. So their emotions are simply agitated in once in a while. No? So that's delusional disorder. So these are other psychotic disorders. They may be out of touch with reality, but the gravity of the disease is not, let's say, equal to that of schizophrenia. So mas kwento, mas okay to, hindi malala. Ang schizophrenia, ang pinakamalala, ito ay pwede pang magamot. Itong mga other psychotic disorders. Tandaan niyo na ang classified disorders ay similar because it has something to do with the disorder of the thinking process. Okay? But the gravity of the disease is different from that of schizophrenia. So again, as I mentioned to you earlier, wala nang gamot ang schizophrenia, pero ang other psychosis may gamot, pwede pa silang bumalik sa kanilang pre-morbid state. Kaya ang dapat nating gawin sa pasyenteng may schizophrenia ay maturuan silang mamuhay ng sarili nila. That's all. They become functional and a little bit productive in any way. And the danger to themselves and to others will be eliminated. That's what we need to think about when we treat about patients with schizophrenia. Always, pag kumuha tayo ng exam, tandaan natin yan. Right? The security of the patient. All the time. Okay? There is also shared psychotic disorders, polyadu, no? Psychotic disorders, delusional usually in one person, no? That is shared by another one, secondary, in a close and dependent relationship. That's why sometimes pag may schizophrenia symptoms yung isang kapatid, maaaring yung other kapatid ay meron din. But that's actually very rare, no? Okay? And then postpartum psychosis, I believe everybody is familiar with this. Other people would actually term it as a postpartum depression. Pero ang postpartum depression is different from postpartum psychosis, no? Here, ano ang symptoms ay mas malala sa postpartum depression. So there is a presence of pluripsychotic symptoms in this case. So delusional, they may have hallucinations, they may have formal thought disorders, no? They may have disorganized behavior or catatonic sign after delivery. So while in postpartum depression, they may have depression only after the delivery of the baby. And this may last for weeks or even months. Sa depression, there is no danger of killing the baby. Pero dito sa postpartum psychosis, may danger of killing the baby in themselves. Yun ang difference noon. Okay? So, moving on with the next question. Question number 6. Okay? So, you have enough input on psychiatric disorders. So, since sinabi ko sa inyo na I prepared 20 questions, so we will answer 14 more questions about schizophrenia. Then after that, we move to mood disorder. Okay? So, any questions so far? Would you like me to explain some more? Or we'll proceed with answering questions that I prepared? Okay. So, question number 6. A continuation of our previous questions, no? A client diagnosed with schizophrenia tells the nurse, okay, something like that, no? Took my shoes out of my room last night, which is an appropriate charting entry to describe this client's statement. I discussed this a while ago to you. So what could be your entry? Okay. A, the client is experiencing command hallucination. B, the client is expressing neologism. C, the client is experiencing paranoia. Or D, the client is verbalizing a word salad. You know, I believe you can answer this question right away, isn't it? Supatolians, no? Or anything like that. These are words that have no meaning in ordinary sense. Ibig sabihin nito, ang pasyente ay nag-create ng kanyang sariling word sa kanyang sariling mundo na siya lamang ang nakakaintindi. Ang ibig sabihin nito, ang pasyente ay nag-formulate ng sariling word, neologism. Ang sagot, no? Sir, what's the difference between letter B and letter D? Neologism. Neologism, creation of new words. Okay? While word salad is combining different words for a sentence. That if you're going to look at the sentence, it has no meaning also. Yes, Rodrigo, you may ask questions if you want to. Rodrigo Cadiante from Dubai, raise hand. Any question? Ronald or Sander, you're there?
Dr. Yes.
Okay.
Rodrigo, are you raising your hand for any clarification?
No, sorry. I just accidentally pressed it.
Okay.
Yeah, okay.
All right. So you know the difference now between neologism and word salad, no? So the word that is mentioned in the question has no meaning at all. So ito yung creation lamang ng pasyente. Okay? So yun ang tinatawag na neologism. So pag ang pasyente ay na-combine ng iba't ibang words to make a sentence, yun ang tinatawag na word salad. Hindi mo rin maintindihan yun. Usually, ito ay ginagawa ng pasyente sa hospital. Marami yan. Pag kinakausap mo, napakahirap intindihin. They have low voice. Sometimes they are catatonic. So when you talk to them, it will be useless to talk to them because you cannot get anything from them. That's why we need to closely monitor them. And once in a while, during the lucid interval, we talk to them. That's we are on the watch out. But here, sometimes when there is a deliberate interview, when we are interviewing the patient, particularly always in the doctor's round in the morning, the doctor will be asked questions, only one, physician I mean, and nothing else. 1 or 2 or 3 questions, that's it. And the patient usually do not answer. It's very difficult to them, particularly in extreme cases of schizophrenia. Yeah? So sometimes they do word salad, they do neologisms also. Okay, so answer is B. The nurse will describe the client's statement as experiencing neologism. I believe there will be a question like this. This is very common amongst patients with schizophrenia. Neologism is when a client invents a new word that is meaningless to others, but may have symbolic meaning to the client. Yung client lamang ang nakakaintindi, as I mentioned to you. On the other hand, word salad refers to a group of words that are put together randomly to make a sentence, although that sentence has no meaning also. So what are we addressing? The client need, psychosocial integrity. All right? Moving on with question number 7. You see? So natakil natin the different types of the schizophrenia a while ago. So I believe you have some basis to answer question number 7 also. During an admission assessment, a nurse asks a client diagnosed with schizophrenia, have you ever felt that certain objects or persons have control over your behavior? So remember this, have you ever felt that certain objects or person have control over your behavior? The nurse is assessing for which type of thought disruption. Delusion of persecution, delusion of influence, delusion of reference, delusion of grandeur. You know, grandeur, delusion of greatness, right? They have bloated expression of the reality of themselves. Like they think that they are God. They think that they are Superman. They think they are the greatest singer of all time. Things like that. Okay? So what could be the possible answer? I repeat the question. During an admission assessment, a nurse asks a client diagnosed with schizophrenia, Have you ever felt that certain objects or person have control over your behavior? The nurse is assessing for which type of thought disruption. A, delusion of persecution. B, delusion of influence. C, delusion of reference or ideas of reference as we are taught in the Philippines. Or D, delusion of grandeur. Right? So the answer is B. What is B? Delusion of influence. Right? All right. So the explanation is the nurse is assessing the client for delusions of influence when asking if the client has ever felt that objects or persons have control of the client's behavior. So other people. Thought insertion, the client controls the thinking of other people. Oh, take note of that. I asked that in question number 5, I think, no? So thought insertion. Pero dito, it's the other way around. Other people are controlling the behavior of the patient. Okay? So the delusion of influence in this case. Delusions of control or influence are manifested when the client believes that his or her behavior is being influenced by other people. An example would be if a client believes that a hearing aid receives transmission that control personal thoughts and behaviors. All right. So what is the client needs that we have here? It's psychosocial integrity. Okay. Moving on with question number 8.
Sir, question.
Yes.
Thank you po. Sir, example po ba nung yung mga tao nagsasabing meron silang yung telepathy, yung nakapag-usap sila sa utak ba? Yung parang nakapagsalita sila sa utak ng ibang tao.
Yes.
Example po ba yun ng ano?
Yeah.
Example po ba yun ng kanina? Yung,
Ganun yun.
yung insertion. Okay po.
Oo. Ganun yun. Parang pwede nilang makausap ang ibang tao using yung utak nila. Ganun yun.
Opo. Yung mga sa mga palabas.
Telepathy really. Okay? Ganun yun. At least naintindihan nyo na, no? Ngayon, so any other question? I appreciate your question. At least I will not monopolize the discussion. Mahirap kasi dito pag nasa university ako, always unidirectional. Sometimes the students do not participate. Very, very frustrating, not like in the Philippines, no? Anyway, any other questions? All right, we proceed with question number 8. A client diagnosed with schizophrenia states. Can't you hear him? It's the devil. He is telling me I'm going to hell. What is the most appropriate nursing reply to the client? So they are already afraid, no? A, did you take your medicine this morning? B, you are not going to hell, you are a good person. Obviously, this is not the right answer, isn't it? C, I am sure the voices sound scary. I don't hear any voices speaking. You may consider that as the answer. See? The devil only talks to people who are not receptive to his influence. Right? Remember, in test taking, you should always consider the appropriate answer, the next possible answer, the best possible answer. It could be A, did you take your medicine this morning? So what could be your rationale if your answer is A? Maybe the patient did not take antipsychotic medication. If that is your answer, then you are not doing your job as a nurse, isn't it? That is not a possible question. That is not a possible answer because that's negligence. In any way, because our duty as nurses would be to give them medicines. And our duty as nurses also is to make it sure that they take the medicine. That's the reason why pag nagbibigay tayo ng medicine among patient with schizophrenia, pinapalabas natin ang kanilang tongue para makita natin talaga that they swallowed. So, hindi natin pwedeng tanungin na, did you take your medicine this morning? You see? Things like that. So, sometimes common sense. So, we eliminate letter A already. What about number B, letter B? You are not going to hell. So, there is already a reinforcement in this case. As if you are reinforcing the good behavior of the patient. No? You are a good person. Affirmation of the person. That sometimes you don't do. Okay? That's the thing that you cannot do to a psychiatric patient. Is it letter C? I'm sure the voices sound scary. You see, that is a very laudable answer. I don't hear any voices speaking. You are not contradicting the patient, but you are presenting the patient a reality. Kasi iba ka sa pasyente. So sabihin mo sa pasyente, I don't hear any voice speaking. Right? Okay. Or C, D, the devil only talks to people who are receptive to his influence. So definitely it could never be D. So the best possible answer is C. Do you understand what I mean? So you are presenting the reality to the patient, but you are also looking into the feeling of the patient. So in psychiatry also, this is actually very tricky, you know? Most of the time, we are looking into the cases of our patients based on their symptoms. We address the need of the patients only based on their symptoms, right? So the answer is C. So the most appropriate reply by the nurse in this case is to reassure. That's reassurance. The client with an accepting attitude, acceptance, while not reinforcing the hallucination. I'm so sure your teacher taught you about reassurance and at the same time, acceptance or accepting attitude. Okay? So the client needs this psychosocial integrity. Now remember, always take note of this. When we are dealing with the patient, we're always in continuous nurse-patient relationship. Our relationship is very, very cordial, and there is spirit of rapport. Rapport means to say we are always connected with the patient in professional way. So we reassure the patient, and at the same time, we are accepting the patient in all way possible. Okay? Question number 9. A client diagnosed with brief psychotic disorder. You see, this is a psychosis different from schizophrenia. A client that is diagnosed with brief psychotic disorder tells a nurse about voices telling him to kill the president. See, there is a commanding voice telling him to kill the president. There is hallucination in this case, auditory hallucination. Which nursing diagnosis should the nurse prioritize for this client? A, disturbed sensory perception. B, altered thought processes. C, risk for violence directed towards others. Or D, risk for injury. As I keep on telling you, yesterday I mentioned to you about this. The first thing that we have to address in cases of psychiatric patients will be the patient's safety and the safety of others. So in here, there is a threat already, no? Something like he is hearing voices telling him to kill the president. So in this case, he is already homicidal in any possible way. There is a danger towards others. So what do you think will happen here? What do you think will be your diagnosis here, your entry here? Is it
alter the process?
altered process? Okay. Any other else?
C.
C, risk for violence. Okay. A, disturbed sensory perception. Right? So,
B or C?
tandaan natin, we are always addressing sa pasyente may psychiatric disorder, we always address security of themselves and others. Okay. What is the answer?
C.
C. So what is C? Risk for violence directed towards others. So that's the first thing that we have to look into. What about disturbed sensory perception? We know that it's already there. This is the last thing that we have to address, right or wrong? Isn't it? So the first thing that we have to address is to make it sure that there is safety of everyone, including the patient. So risk for violence directed to others or sometimes directed to themselves. So that's actually what we need to address. Always tandaan natin yan. No? Always safety and security. Okay? Yung altered thought process, hindi naman natin magagamot kagad yan eh. Halimbawa, nagsasabi silang, oh, may nakikita ako, ganyan-ganyan. Hindi naman natin magagamot kaagad yan. So, i-address kaagad natin yung immediate need. Halimbawa rito, although there is altered thought process, kasi nga, there is hallucination. But that's the last thing that we have to address. The thing that we have to address first will be the security of other people. No, somebody is commanding him to kill the president. Who knows that other boys will actually tell him, oh, the person in front of you is the president. You see? Somebody is telling, kill the president, then another boy say, somebody in front of you. That somebody in front of you is the president. So, there is a danger. Right? So usually this is actually the problem that we have, no? Particularly with the hallucinations, auditory, paranoid type, schizophrenia. All right? So the nurse should prioritize the diagnosis risk for violence directed toward others. A client who hears voices telling him to kill someone is at risk for responding and reacting to the command hallucination. Okay? Telling someone is a command hallucination. Other risk factors for violence include aggressive body language, verbal aggression, catatonic excitement, and rage reactions. They are shouting already, especially when the voices are actually very prevalent. So the client need that we are addressing here is psychosocial integrity. Okay? So always take note of that, patient safety and safety of others. That's the first thing that we have to address for any cases of psychiatric disorders. Question number 10. Which nursing intervention would be most appropriate when caring for an acutely agitated client? Agitated na naman to with paranoia, you see? For an acutely agitated client with paranoia. They are very suspicious and they are very agitated. This could be present among patients with schizophrenia, paranoid type. This could be present among patients with delusional disorder. This could be present among patients with bipolar disorder. So very agitated yan, sumisigaw yan, very violent yan. So the behavior is actually very violent. Sometimes nagsisigaw, malakas, kinakabog kung ano-ano doon, no? So what do they have? Are we going to have this, no? Provide neon lights and soft music, melotherapy. Maintain continual eye contact throughout the interview. Use therapeutic tasks to increase trust and rapport. Or provide personal space to respect the client's boundaries. What do you think will be the answer? Again, I repeat the question. Which nursing intervention would be most appropriate when caring for an acutely agitated client with paranoia? Are we going to restrain immediately the patient? Or is it A, provide neon lights and soft music, melotherapy? B, maintain continual eye contact throughout the interview. Of course, letter B, you cannot do that. You understand what I mean? The patient is already shouting. Or is C, use therapeutic touch to increase trust and rapport? Can you do that? When the patient is very agitated? Or letter D, provide personal space or bound to respect the client's boundaries. What do you think is the answer?
D.
All right. So let's see. Okay. That's correct. Why? Remember this. In number 1, provide neon lights and soft music. That's not the emergency nursing intervention that you're actually going to do. Nagsisigaw-sigaw na yung pasyente. Lumayo ka muna sa pasyente. Make it sure that there are no sharp objects at walang kahit na anong object na pwedeng mabasag at kahit na anong object na pwedeng maka-injure sa pasyente. Okay? Then pakalmahin ang situation, bumalik ka. Right? Afterwards. Sir, why is it that you do not actually use the medicine to calm the patient down? Sometimes patients do not need medicines in this case. Sometimes patients are acutely agitated just because they're threatened by us. Sometimes when the patients are actually coming to us, particularly it's the first time to be admitted in the hospital, there are so many issues that we have to address. So giving them privacy is the most important nursing intervention that we can actually do, no? So that we will show that we respect the patient in any possible way. So the most appropriate nursing intervention is to provide personal space to respect clients' boundaries. Providing personal space may serve to reduce anxiety. Anxiety may cause agitation in any possible way, and thus reduce the client's risk for violence. So in that case, we are addressing the client need on psychosocial integrity. Anxiety breeds anger and agitation. See, anxiety, as I mentioned to you earlier, is one of our primordial emotions. Sometimes anxiety will make us react. Anxiety, in any possible way, will help us to prepare for the solution of any possible threat that we have. See, we perceive that other people and our presence in the hospital would be a threat. That's the reason why some patients actually are reacting negatively in any way. So what is the reaction in this case? A feeling of agitation and violence. So sometimes, pag lumayo tayo, at least mga about 5 minutes, then we have to go back when the patient calm down already. Although we keep on telling that you have to stay with your patients most of the time, although they are not talking, in this case, it's another story because the patient is actually being violent already. There is acute violence. So acute agitation. So the best thing that you can actually do to address the situation is to leave the patient alone for a period of time to let him calm down. All right. Question number 11, we're still on schizophrenia. Okay. Which nursing behavior will enhance the establishment of a trusting relationship with a client diagnosed with schizophrenia? Always in psychiatric nursing, we are maintaining trusting relationship. So what do we do as nurses to maintain that with our patients? A, establishing personal contact with family members. Tinuturo sa atin yan na hindi pwede, di ba? Pagtawag ng telepono, let the social workers do that. That's not our job. B, being reliable, honest, and consistent during interaction. Possible, right? C, sharing limited personal information. That's impossible, isn't it? We may not actually share our personal information in any way. D, sitting close to the client to establish rapport. See, that's close. So the most possible answer will be D and D, isn't it? So what's your choice? So A is eliminated, C is eliminated, so B and D are the possible answers. So nag-eliminate na kayo. Sometimes it happens in the board examination. By the way, huwag kayong mag-leave ng kahit na anong number. Alright? Basta huwag na kayong huwag niyong sabihin pag sumasagot kayo sa examination. That's not, no. You leave your answer blank. You should not do that. At least you should have a choice. Then you make a mental note or jot down nyo yung number na pwede nyo balikan eventually. But wag na wag kayo mag-leave. Do not leave any question. Just go and answering. So chances are sometimes, and do not stay in one question for a very long time because it's always, I believe a question is designed to be done in 2 to 3 minutes. So do not stay more than 3 minutes. Do not stay more than 2 to 3 minutes. So you just stay within time frame, and as much as possible, if you do not know the answer, you address the question by elimination. If A is not possible or it could not be possible, B could not be possible also, then it should be C or D. Then choose the best answer. That's how you're going to do in test taking. Okay? So in this case, what are you going to do? Is it B or D or any other answer? So the answer is B. Okay? Being reliable, honest, and consistent during the interaction. Sir, pwede rin naman sitting close to the client to establish rapport. Remember, sitting close to the client to establish rapport will only be done during the working phase when you have established the trusting relationship already. Remember the different stages of establishing relationship with the patient, isn't it? So you have to maintain trust. That's the first thing. How do you maintain trust? You know, it will take time. Communicate with the patient, becoming honest with the patient. So in that case, you can sit side by side with the patient. You can only do that when you have achieved already trust of the patient and you are already on the working phase of your interaction with the patient. So the possible answer is B. The nurse can be enhanced the establishment of a trusting relationship with the client, diagnosed with schizophrenia by being reliable, honest, and consistent during interactions. The nurse should also convey acceptance of the client needs and maintain a calm attitude when dealing with agitated behavior. Psychosocial integrity. Okay? That's letter B. Question number 12. Client diagnosed with schizophrenia states, my psychiatrist is out to get me. I'm sad that the voice is telling me to stop him. What symptom is the client exhibiting and what is the nurse's legal responsibility related to this symptom? A, magical thinking. You administer an antipsychotic medication immediately. B, persecutory delusions. Orient the client to reality. Possible, isn't it? Okay, because the patient is very suspicious already. My psychiatrist is out to get me. That's delusion of persecution. Or is it C, command hallucination? Is there any command in there? Warn the psychiatrist. Are you going to do that? If you're going to do later C, the patient will, the psychiatrist will fire you immediately. You're not fit to become a psychiatric nurse. No? Or D, altered thought processes. Call an emergency treatment team meeting. Are you going to do that? So by elimination, you may know that the answer is not C or not D, not even A. So the answer is B, isn't it? That's how you're going to make an answer. Of course, you may justify your answer in any possible way. When you read the question, you know already that the patient has delusion. So what are you going to do? Orient the client to reality. That's your job as a nurse, as a psychiatric nurse. All right? Then number 13, which statement should indicate to a nurse that an individual is experiencing a delusion? A, there is an alien glowing in my liver. B, I see my dead husband everywhere I go. C, the government may audit my taxes. D, I'm not going to eat my food. It smells like brimstone. You see? Which statement should indicate to a nurse that an individual is experiencing a delusion? So makikita nyo na ang pasyente ay may delusion pag ang pasyente ay nagsabi ng ganito. A, there is an alien growing in my liver. Okay? Is it B, I see my dead husband everywhere I go. So I see. Is this delusion or hallucination? So it could never be B because B is hallucination. Okay? Or is it C, the government may audit my taxes? Or D, I'm not going to eat my food. It smells like brimstone. This is also hallucination. Letter D, it smells. Olfactory hallucination. What about there is an alien growing in my liver? Or I see, or C, the government may audit my taxes, right? The answer could be A and C, right? So let's see. Okay, so the answer is A. Why? The nurse should recognize that the client who claims that an alien is inside his or body is experiencing a delusion. Delusions are false personal beliefs that I mentioned to you earlier that are inconsistent with the person's intelligence or cultural background. Psychosocial integrity, why not C? Because it's highly probable that the patient, that they are actually going to audit taxes, you know? Chances are, the patient who may actually be in the hospital is not working already. So the answer may not actually be C. So the answer or the choice that we may actually have is A. Question number 14. Psychopharmacology. let's try to look into antipsychotic medications that we may actually have. A client diagnosed with schizophrenia is slow to respond and appears to be listening to unseen others. There is always the hallucination in this case, visual. Which medication should a nurse expect a physician to order to address this type of symptom? There is a visual hallucination. What are we going to give? A, haloperidol. B, clonazepam. C, risperidone. Or D, clozapine. These are all antipsychotic medicines that we give to the patients. So what do we usually give to the patients who do have hallucinations? Take note, it's actually very important that you should know this, because I think in the examinations, they may ask questions like this 3 or 5 times. So the answer is C. What is C? Risperidone, right? To address the positive symptom. We know for a fact the positive symptoms do have hallucinations and delusions. Haloperidol, we do not have. The hallucination is not in there. Okay? And for letter D, negative symptom is also mentioned here to address negative symptom. We know for a fact that we can eliminate A and D because the problem that we have with the patient is hallucination. And hallucination is included in the positive symptoms of schizophrenia. So it's either clonazepam and risperidone, but most of the doctors prescribing, most of the doctors are treating hallucination using risperidone or risperidone in this case. Okay? So risperidone is an atypical antipsychotic used to reduce the positive symptoms, including disturbances in the content of thought, form of thought, the neologisms, or sensory perceptions, hallucination. This is the most common. And in fact, this is actually being used right now in hospitals. No? So the client needs that we are addressing physiological integrity, pharmacological, and parenteral therapies. Okay? So question number 15. Another antipsychotic medications. A client is diagnosed with schizophrenia. A physician orders haloperidol, the Haldol, 50 milligram BID, benzotropine, cogentin, 1 milligram as necessary, and solpidem, the Ambien, 10 milligram before sleeping or during sleeping hour. Which client behavior would warrant the nurse to administer benzotropine? A, tactile hallucination. No. So the patient is diagnosed with schizophrenia, all right? So what do we have here? Tardive dyskinesia, restlessness and muscle rigidity, or reports of hearing disturbing voices. What are we addressing here? Okay, so the medication that was actually given is Haldol, and Haldol is usually given on patients with negative symptoms. So what do we have? So definitely we're not going to address A, hallucinations, because hallucination is a positive symptoms. So what do? We address muscle rigidity because muscle rigidity is a form of catatonia already. Okay, haloperidol is the best thing, the best medication that we actually give to the patient. No, so the symptom of tactile hallucinations and reports of hearing disturbing voices would be addressed by antipsychotic medications such as haloperidol. Tardive dyskinesia, a potential irreversible condition, would warrant the discontinuation of an antipsychotic medication such as haloperidol. An anticholinergic medication such as benzotropine would be used to treat the extrapyramidal symptoms of restlessness and muscle rigidity. We do not have Akiniton this time, but before, earlier in the 1990s, in order to combat extrapyramidal syndrome, we have Akiniton together with chlorpromazine. So what are the client needs that we are addressing? Physiological integrity, pharmacological and parenteral therapies, among others. Now, question number 16. A nurse is caring for a client who is experiencing flat affect. paranoia. Anhedonia. Anhedonia is a symptom of schizophrenia where the patient does not experience happiness or joy to things that he does before. Anergia, lack of energy, neologisms, and echolalia. Which statement correctly differentiates the client's positive and negative symptoms of schizophrenia? Tactile hallucination, tardive dyskinesia, restlessness and muscle rigidity, reports of hearing disturbing voices. Okay? So the answer is B, tardive dyskinesia. Why? The nurse should recognize that positive symptoms of schizophrenia include paranoid delusions, neologisms, and echolalia. These are all positive symptoms, no? So the negative symptoms of schizophrenia include flat affect, anhedonia, and anergia. Positive symptoms reflect an excess or distortion of normal functions. The negative symptoms reflect a decrease or loss of normal functions. So what we are addressing here on the needs of the client, physiological integrity. Moving on with question number 17. A client diagnosed with schizophrenia who has been taking antipsychotic medication for the last 5 months. Presence in an emergency department with uncontrollable tongue movements, stiff neck, and difficulty swallowing. The nurse would expect the physician to recognize which condition and implement which treatment. So what is the condition of the patient and what type of treatment that will be addressed by the physician in the emergency department? Usually in the emergency department, we have only residents on duty, not a psychiatrist. Sometimes they call the psychiatrist on duty in the psychiatric ward. But normally, they immediately give medication when they see patients like this. So what type of conditions that the physician in the emergency department is addressing? A, neuroleptic malignant syndrome that can be treated by discontinuing antipsychotic medications. B, granulocytosis that can be treated by administration of clozapine or clozaril. EPS, extrapyramidal symptoms or syndrome as we call it in the Philippines, treated by the administration of benzotropine or cogentin. Or is it D, tardive dyskinesia, treated by discontinuing antipsychotic medications? Remember, ang tinatanong dito ay condition at kung ano ang dapat gamot na pwedeng i-prescribe ng physician sa emergency department. The physician may not necessarily be a psychiatrist. Right? So what do they usually give? All right. So the answer is tardive dyskinesia. Right? So what do we have here? So we need to stop the antipsychotic medications immediately. The nurse should expect that the ED physician would diagnose the client with tardive dyskinesia and discontinue antipsychotic immediately. Tardive dyskinesia is a condition of abnormal involuntary movements of the mouth, tongue, trunk, and extremities that can be an irreversible side effect of typical antipsychotic medications. Physiological integrity is being addressed here, including pharmacological and parenteral therapies. All right. So, last 3 questions for schizophrenia. A client who is admitted to the inpatient psychiatric unit and is taking Turazine, this is usually the basic medication that we give in the Philippines and the UAE, chlorpromazine, no? Presents to the nurse with severe muscle rigidity, tachycardia and temperature of 105 Fahrenheit, or that's equivalent to 40.5. It's already febrile, no? The nurse identifies these symptoms as which of the following conditions? A, neuroleptic malignant syndrome. C, tardive dyskinesia. C, acute dystonia. And D, agranulocytosis. Right? The answer is neuroleptic malignant syndrome. The neuroleptic malignant syndrome is potentially fatal condition characterized by muscle rigidity, fever, altered consciousness, and autonomic instability, right? So the thing that we are addressing the client needs is physiological integrity. Okay. So question 19. A client is diagnosed with schizophrenia, takes an antipsychotic agent daily. Which assessment finding should a nurse immediately report to the client's attending psychiatrist? Ano ang i-report natin sa psychiatrist, no? Respiration of 22 beats per minute, weight gain of 8 pounds in 2 months, temperature of 104 Fahrenheit or 40 degrees Celsius, or excessive salivation. Tandaan natin lahat ng antipsychotic medication na tinitik ng pasyente ay may side effect. So anong i-report natin sa pasyente? So immediately, the thing that we need to report will be the thing that can threaten the integrity of the patient's physiological functioning. So in this case, if the patient has temperature of 104, so that's the first thing that need to be addressed. Okay? So when assessing client diagnosed with schizophrenia who takes antipsychotic agent daily, the nurse should immediately address a temperature of 40 degrees Celsius. Okay? So it threatens the patient's integrity in this case. A temperature this high can be symptom of a rare but life-threatening neuroleptic malignant syndrome. You know, this is one of the side effects that we may actually assume when a patient is taking antipsychotic medications. So still, we are addressing physiological integrity among clients with psychiatric disorders. And this is the last question on schizophrenia. An elderly client diagnosed with schizophrenia takes an antipsychotic and beta-adrenergic blocking agent like propranolol for hypertension. Understanding the combined side effects of these drugs, the nurse would most appropriately take which statement? Propranolol is actually very common prescriptive drugs for hypertension that we have in the psychiatric ward, no? Is it A? Make sure you concentrate on taking slow, deep cleansing breaths. Watch your diet and try to engage in some regular physical activity. Or is it C? Rise slowly when you change position from lying to sitting or sitting to standing. Or is it D? Wear sunscreen and try to avoid midday sun exposure. Right? So obviously it could not be D. The answer is C. So the most appropriate statement by the nurse is to instruct the client to rise slowly when changing position, slowly going up, no? Antipsychotic medications and beta blockers cause a decrease in blood pressure. There could be a danger of hypotension in this case, no? So when given in combination, this side effect places the client at risk for developing orthostatic hypotension. So combination of the two. So bababa ang dugo at ang maaaring ko niyan, magkuha ng pasyente, matumbang pasyente at it may cause injury to the patient also. So when the patient is actually going to stand up, we instruct them to stand slowly, right? So the client needs that we are addressing will be physiological integrity, reduction of risk potentials, no? All right, that ends our psychiatric nurse schizophrenia. So any questions so far about schizophrenia before we'll proceed to another disorder? Because I prepared at least 50 questions. Ronald, until what time are we supposed to be with the students?
Until we finish the lecture, doctor.
So,
Okay, maybe we can ask the students if they are willing to finish all the topics, because this is this is a great opportunity, no? To listen, especially with the mood disorders. These are common questions in the board exam, and also with the schizophrenia. They need to attend to.
are you still with me? Can we go on? There are 30 more questions. Anyway, I'll try to move fast, no? And in between, there are topics that I really would like to emphasize and discuss, no? So I'm still willing to move on. Okay, Ronald, shall we move on?
Sure, doctor, go on.
Okay. So next question. This is pertaining to different topic already. Okay. This is pertaining to mood disorder. I would like to start with number 21. 21 to 30 actually, no? So the question number 21 goes like this. A highly agitated client faces the unit and states, I could buy and sell this place and move to and fro. The client's mood fluctuates from fits of laughter to outbursts of anger. So, tumatawa siya, then agitated at angry. What is the most accurate documentation of this client's behavior? By the way, if you can actually a patient like this, you can see a patient like this, tumatawa at agitated, ano ang unang nasa isip ninyo? Bipolar disorder, right? Isn't it? So the patient is actually on the opposite pole. All right? Okay. So rates mode A, rates mode actually is 8/10, exhibiting looseness of association, euphoric. Okay? That's on the opposite side, on the side of mania. Mode euthymic, exhibiting magical thinking or restless. C, the mode is labile, exhibiting delusions of reference, hyperactive. Or is it D, agitated and pacing, exhibiting grandiosity, mood labile. Grandiosity, is it? I can buy and sell this place. Remember, in a patient with bipolar disorder, they may experience also symptoms of delusions and hallucinations. The two positive symptoms of schizophrenia. All right? What could be the possible answer in 21? It's D, right? So the nurse should document that this client's behavior is agitated and pacing, exhibiting delusion of grandeur, grandiosity, bordering towards labile mode. No, labile mode, flat mode, no? So the client is exhibiting signs of irritation accompanied by aggressive behavior. Grandiosity refers to an exaggerated sense of power, importance, knowledge, or identity. This is obviously a delusion of grandeur. Okay, a positive symptoms that can be found also in schizophrenia. The client needs safe and effective care environment. Right. Question number 22. A client diagnosed with bipolar 1 disorder is distraught over insomnia, experienced over the last 3 nights, and 12-pound weight loss over the past 2 weeks. Hindi natutulog. Which should be this client's priority nursing diagnosis. Ano ang unang nursing diagnosis natin dito? Okay? There is always a priority nursing diagnosis. A, knowledge deficit related to bipolar disorder as evidenced by concern about symptoms. B, altered nutrition, less than body requirements related to hyperactivity as evidenced by weight loss, possibly. Rest for suicide related to powerlessness as evidenced by insomnia and anorexia. Or is it D, altered sleep patterns related to mania as evidenced by insomnia for the past 3 nights. So, nandun lahat yung mga different symptomatology na makikita natin sa questions. So, what would be our priority nursing diagnosis? Always tandaan natin na ang ating priority will be patient safety and security. Always titingnan natin yan sa lahat ng pasyenteng nandoon sa psychiatric ward. So our answer will be B, no? Altered nutrition. So this is actually necessary. Why? Because the patient already lost weight. So the patient is endangered already because he is not eating. He is not sleeping. So definitely there is a possibility that the patient health may be compromised. So the nurse should identify that the priority nursing diagnosis for this client is altered nutrition. Makikita mo yan sa mga pasyente, biglang papayat. May problema yan. Kasi lahat ng mga antipsychotic medications na ibinibigay natin sa hospital ay nagpapataba. Hindi nagpapapayat. No? So usually, yun ang kanilang yun ang kanilang side effects, no? Pero pag pumayat ng pasyente din, malamang malaking problema yan. So we have to address that because we need to address the physiological integrity of the patients, no? So the patient lost already 12 pounds, around 5 kilograms, no? All right. So the answer should be altered nutrition, less than body requirements related to hyperactivity as evidenced by weight loss. Due to the client's rapid weight loss, the nurse should prioritize interventions to ensure proper nutrition and health. Maraming kwan yan, magkakaroon ng maraming medical conditions yan. Alright? So, next question. A nurse is planning care for a client diagnosed with bipolar disorder, manic episode on one side. Okay? In which order should the nurse prioritize the listed client outcomes? So, ano ang pwede natin gawin pag sunod-sunurin? So, we have to prioritize our nursing interventions. Is it 1, maintain nutritional status, interact appropriately with peers, remains free from injury, sleep 6 to 8 hours a night? Okay? As I mentioned to you, again, tandaan natin na ang ating intervention sa mga pasyenteng may mental disorder ay yung security, ay yung kanilang kaligtasan, they are free from injury. So the first thing that we have in mind immediately, it's a no-brainer. When we see this, we have to place number 1 as remains free from injury. See? Other questions, so hanapin natin yan sa choices, which actually place 3 as number 1. So it's only letter C. Hanapin natin, is it A, B, or D? So we will not look into others. No, pag nakita natin remains free from injury, the answer should be C. Isn't it? So always remember, the patient's integrity, the patient's safety and security must always be the primordial considerations that we have to, no matter what. No matter what diagnosis the patient may actually have. They may have mood disorder, they may have personality disorder, they may have anxiety disorder. The first priority nursing interventions that we have to look into will be on the patient's safety and security. So obviously the answer is C. Hanapin natin ABC, C lang ang may number 3. So the answer is actually letter C. Okay? It's a no-brainer. All right? So the nurse should order client outcomes based on priority in the following order. Remains free from injury. Okay? Maintains nutritional status, sleeps 6 to 8 hours a night, and interacts appropriately with peers. Huwag na kayong mag-isip pag nakita nyo yung ganun, no? Pag first answer nyo ay ganun na, yung inaharap nyo ay ganun na, then do not think twice. Ang nangyayari kasi, nagdo-double thinking tayo paminsan-minsan sa sagot natin. So, we leave it blank. Then we go on to the next question. That you should not do and that you must not do. Chances are sometimes, hindi mo matatapos ang examination, hindi mo na mababalikan yung nalagpasan mo. Immediately, you have to answer it. The first thing that comes in your mind. So the nurse should prioritize the client's physical and safety needs. Always look into that. Sa psychiatric nursing considerations, we have to look into patient's security and safety. And of course, the security and safety of others. Number 24, a client diagnosed with bipolar disorder, depressive episode, mentally overdoses on sertraline, Zoloft. Family reports that the client has experienced anorexia, insomnia, the recent job loss. What should be the priority nursing diagnosis for this client? Okay. A, risk for suicide related to hopelessness. Okay. Kagad yon, nakikita natin, A is already safety and security consideration. B, anxiety, severe, related to hyperactivity. C, imbalanced nutrition, less than body requirements related to refusal to eat. Or is it D, dysfunctional grieving related to loss or employment? What do you think is the answer? Right. No answer? Okay. This is very obvious, isn't it? Tingnan natin, yung pasyente sa question natin ay nag-overdose, nagpakamatay. So, it's a no-brainer. So, lahat ng mga choices na binigay natin, na makikita natin, addressing secondary needs of the patient. The first need of the patient is actually the danger to himself. So risk for suicide related to hopelessness, nawalan siya ng trabaho. You see, hindi siya makatulog, hindi siya makakain. So there is danger that the patient may actually kill himself. So it's a no-brainer. Always, again, reminder, I keep on telling you, this will always come out in the exams. The first thing that you have to consider in addressing the need of the patient will be his security and safety, and security of others, and safety of others. Danger for suicide and danger for homicide. All right. Next question. A client diagnosed with bipolar 1 disorder, manic episode, refuses to take lithium carbonate. A lithium carbonate is drug of choice for patients with bipolar with the mood disorder because he complains that it makes him feel sick. Which of the following medications might be alternatively prescribed as mood stabilizer in bipolar disorder? So if a patient is diagnosed with bipolar disorder, the drug of choice would always be lithium carbonate. This is the well-known mood stabilizer. Are we going to give Sulof, Dipacot, Disrael, or Paxil? Paroxetine, no? So usually we give valproic acid. Okay? Side by side with lithium. If we're going to give lithium carbonate, then we may not give valproic acid. But usually, if a patient, valproic acid is well-known mood stabilizers that we have in the market today. So although lithium is a prototype drug in the treatment of bipolar disorders, so anticonvulsant is actually needed, such as valproic acid, to stabilize the mood. Okay? So that's why you notice that if a patient do have actually problems in mood, particularly in depression, and their mood is actually not so stabilized, so anticonvulsants is actually given most of the time, and valproic acid is actually readily available in the market. No, so the client need will be safe and effective care environment. Question number 26. A client diagnosed with bipolar 1 disorder is exhibiting severe manic behaviors. A physician prescribed lithium carbonate, escalate, no? Sometimes escalate, then olanzapine. This is very common. So the client's spouse questioned the Psychiatric order. What is the need for Psychiatric? What is the most appropriate nursing reply that you may actually give to the client's spouse? So Psychiatric in combination with escalate cures manic symptoms. Psychiatric prevents extrapyramidal side effects. Psychiatric ensures good night's sleep. Or Psychiatric counts hyperactivity until escalate takes effect. Right? So usually we can give letter D as the answer. So the nurse should explain to the client's spouse that Psychiatric can calm hyperactivity until the escalate takes effect. Okay, so the separate is fast acting. No, so escalate may take 1 to 3 weeks to begin to decrease hyperactivity. So it takes time for escalate. So we need immediate control. We need immediate mood stabilizer in any way. Okay, so Psychiatric is classified as an antipsychotic, though that can control the positive symptoms like hallucinations and delusions. It can be used immediately to reduce hyperactive symptoms in acute manic episodes. The client need that we are addressing here is health promotion and maintenance. Okay? Question number 27. A client began taking lithium for treatment of bipolar disorder approximately 1 month ago. Okay? The client asked if it is normal to have gained 12 pounds in this time frame. What is the appropriate nursing reply? You know, for a part that lithium carbonate side effect would be increased body weight. Are you going to say that's strange? Weight loss is the atypical pattern, or what have you been eating? Weight gain is not usually associated with lithium. Or C, weight gain is a common but troubling side effect. Or D, weight gain occurs only during the first month of treatment with this drug. So the way you communicate with the patient, C is the right answer, right? So the nurse should explain to the client that weight gain is a common side effect of lithium carbonate. As I mentioned to you, the moment you start taking lithium carbonate, chances are you are going to expect a weight gain, especially in the first month, second month, no? So the nurse should educate the client on the importance of medication compliance and discuss concerns with the prescribing physicians if the client does not wish to continue taking the medication. Usually, the patient's size double. I'm telling you, I've experienced this, particularly those who are taking lithium carbonate. I have patients who took lithium carbonate whose diagnosis is borderline personality disorder that I'm going to discuss eventually later on to you. Her weight doubled in time. Question number 28. A nursing instructor is teaching about the prevalence of bipolar disorder. It's very common. Where the student statement indicates that learning has occurred. Where is the appropriate nursing reply? You should know this, no? This disorder is more prevalent in the lower socioeconomic groups. This disorder is more prevalent in the higher socioeconomic group. Or this disorder is equally prevalent in all socioeconomic group. Or D, this disorder prevalence cannot be evaluated on the basis of socioeconomic groups. So the answer is actually letter B. The nursing student is accurate when stating that bipolar disorder is more prevalent in higher socioeconomic groups. Okay? Nakakaangat sa buhay. Theories consider both hereditary and at the same time environmental factors in the etiology of bipolar disorder. Client need, health promotion, and maintenance. So don't worry, if a patient is diagnosed with bipolar disorder, they can be treated and they can go back to their pre-morbid state. Positive symptoms of schizophrenia that is present in bipolar disorder may be eliminated in time. Right? Moving on with question number 29. A client diagnosed with bipolar disorder who has taken lithium carbonate like 10 for 1 year, or expect the body bloated, increase in size, presents in an emergency department with severe diarrhea, blurred vision, and tinnitus. How should the nurse interpret these symptoms? Is there any toxicity? So let's say, A, symptoms indicate consumption of foods high in tyramine. B, symptoms indicate lithium carbonate discontinuance syndrome. Or is it C, symptoms indicate the development of lithium carbonate tolerance? Or is it C, symptoms indicate lithium carbonate toxicity? So what we are presenting here is toxicity already. So makikita natin dito, severe diarrhea, blurred vision, and tinnitus. So these are all signs of toxicity. So the nurse should interpret that the client's symptoms indicate lithium carbonate toxicity. So immediately the best thing that we can actually do is to stop the medications and give another mood stabilizer. So the initial signs of toxicity include ataxia, blurred vision, severe diarrhea, nausea, and vomiting, and tinnitus. So lithium levels should be monitored monthly during maintenance. That's the reason why every month the lithium level must always be gauged, must always be monitored. So may laboratory po niyan. Pag ang isang pasyente ay nagtitik ng lithium carbonate, expect that the doctor's order will always be accompanied with monthly monitoring of the lithium level in the blood. So it's very important in order to prevent lithium toxicity. This is the responsibility of the nurse and doctor to monitor the level of lithium toxicity. Sometimes if a lithium is given with another antipsychotic medications or is another medications, antidepressants, sometimes it can actually be deadly. No, there is interactions between medications. Client needs physiological integrity, pharmacological, and parenteral therapies. So question number 30. A nursing instructor is discussing various challenges in the treatment of clients diagnosed with bipolar disorder. Which student statement demonstrates an understanding of the most critical challenge in the care of these clients? What are the critical challenges that we are encountering? How should the nurse interpret these symptoms? Treatment is compromised when clients can sleep. B, treatment is compromised when irritability interferes with social interaction. C, treatment is compromised when clients have no insight into their problems. Or The treatment is compromised when clients choose not to take their medications, right? So usually the problem that we have is that the clients refuse really to take medication. And you know for a fact that this is one of the patient's right. Patients always have rights. So our answer is B. If the client does not want to take medication, really it's a challenge. In psychiatry, it's actually very important. It's one of the patient right. Always remember this, no? Do not insist if the patient does not want. So that maybe one of the questions will be asked like this in the board examination. Are you going to give medication if the patient refuses to take medications? The immediate answer is no, because the patient has a right. In psychiatry, no sir, but he has psychiatric disorder. No matter what, he also has a right. You may not give. Okay? So that's how it should be. So the nursing student should understand that the most critical challenge in the care of clients diagnosed with bipolar disorder is that treatment is often compromised when clients choose not to take their medications. No? Another one is that sometimes the patient may not understand what they are taking because the nurses, student nurses do not explain to them what would be the effect and what would be the interaction. That's why it's very important for us to know about the drugs that we are actually giving to the patient. Now, symptoms of bipolar disorder will reemerge if medication stops. This is always the problem. That's the reason why it comes back. Okay? Although treatment is 100% probable, possible in bipolar disorder, we can treat that. The patient can always go back to the pre-morbid state. So the client needs physiological integrity, pharmacological, and parenteral therapies. On the next slide, I really would like to show to you the different mode range. No, so I think there is another questions in number 31. Before I will discuss about the different ranges of modes that we have. Why is it that we call bipolar disorder as such? So let's go on the question number 31. A client is diagnosed with persistent depressive dysthymia disorder. Dysthymia is under mode disorder. Which should the nurse classify as an affective mode of this disorder? A. Social isolation with focus on self, low energy level. C. Difficulty concentrating, or D. Gloomy and pessimistic outlook on life. So, yung ito bipolar disorder nito, pero ang kanilang range of mode is mababa. So what do we have here? No? The nurse should classify gloomy and pessimistic outlook on life, not bordering towards suicide, as an affective symptom of dysthymia. Symptoms of depression can be described as alterations in 4 areas of human functioning: affective, behavioral, cognitive, and physiological. Now, affective symptoms are those that relate to the mode. Now, on the next slide, you will be able to see the different mode range. I would like you to look at this now. So there are 2 poles para maintindihan natin yung bipolar disorder. Ito nasa gitna, yung behavior mo, ang iyong mode ay actually, you can balance between being happy and being sad, you're normal. So there is always a range. In bipolar disorder, the change or shifting of behavior, maybe a week or maybe very fast, from end to end. The patient may actually be depressed, severely depressed, then in one day or in another hour, the patient may actually be euphoric. In this case, very manic. Okay? So the condition of depression in this case is severe. So matatandaan natin dito na makikita natin dito ang different levels of depression on this side, right? On the other pole. This is the other pole. This is the negative pole also, where depression can be classified as such. So from end to end yung bipolar. Pero dito, yung tinatawag nating cyclothymic, ang baba rito. So, in between. So, ang range of mode nila ay bordering toward mild depression to hypomania. So, mababa lang, right? So, hindi mo makikita dito ng signs and symptoms of suicide. Maybe maaring very, very sad sila, or maaring sometimes very, very happy sila. Still bipolar, no? In any way. Then, sa unipolar, one-sided. In this case, ang symptomatology talaga is depression. Hindi pumupunta dito sa kabila. Hindi nagiging masaya. Basta depressed lang sila for a very long period of time. Maaaring ang kanilang depression may be mild, maybe moderate, or maybe severe. Ang unipolar is a major depression in which case the patient may be suicidal. And most of the cases diagnosed with unipolar disorder would be under severe depression, which we call as clinical depression. So, integrity ng patient will be threatened in this case. May experience ng suicidal ideation. Then here is the dysthymic disorder. So, nag-range lang ng very mild, right? From very sad to very happy only. Not very, very, very happy in that case. So, in that case, the mood range only for very, very short period of time. Although, it's not healthy because the thing that I mentioned to you earlier is that the patient may become dysfunctional in any way. All right? It becomes disorder because the patient has dysfunctionality. So mood disorders can be classified into major syndromes, namely depression and mania. As I mentioned to you, depression and mania on the other side. Both unipolar, they could have mania, they could be clinically depressed. So people who suffer from manic illness will invariably have depression, as well as sometime in life, and this type known as bipolar mood disorder. You see? So, transferring from one mood to another. So, the transition of the mode may be very quick. It may happen in minutes, or it may happen in hours, or it may happen in weeks. That's how it goes. No? So, in major depression, it's one-sided, it's unipolar. This is characterized by repeated episodes of depression only. Depression lang, hindi nagiging manic. Kaya unipolar, doon lang siya. Kaya tinatawag nating clinical depression in that case. Right? Then in the case of dysthymia, this is a chronic depressive syndrome for 2 years or more. Yung mode is actually very, yung transition is very quick, but it will last for 2 years or more, but depressive symptoms are not as severe as in the depressive disorder. Yung makita natin ng depression is not very severe. Parang malungkot lang siya. You know, they can live with the society, they can live without medications actually. Parang yung mukha nila nakikita natin tambak all the whole year. Something like that, no? They have no, there is no danger that they can commit suicide in this case. So they can control also their negative symptoms in this case, the depressive symptoms. So what do we have in depressive disorders, the prevalence? Let's try to look on the epidemiology. Of course, mas marami ang babae. Maaring tanong sa inyo sa board examination to, ha? Ang depressive disorder is very prevalent among female, no? So 1:2. Okay? So 2 to 5% in life prevalence varies between 10 and 20%, no? At the age of onset, this is becoming lower with more young people getting the illness. No? The lifetime prevalence of dysthymia, on the other hand, is common in women younger than 65, single unemployed persons from low socioeconomic status. In some literature, depressive disorder may appear among patients who are teenagers and those people who are actually old, elderly. So makikita natin yan sa mga taong elderly. So, ang comorbidity, mayroon symptoms ng anxiety. These are very common in the depressive disorder. Madaling ma-anxious. Okay? Depressive features are quite frequent in the following. All right? Generalized anxiety disorder, we call it GAD. Panic disorder, we have that in the 4th level of anxiety. Anxiety, as I mentioned to you, I think earlier, there are 4 levels here. That's very common among us. We have we have mild, moderate, severe, and panic attack. We have the level of OCD also, obsessive compulsive disorder. schizophrenia, schizoaffective disorder, eating disorder, substance use disorder, and personality disorder, right? These are comorbidities that are very common among depressive disorder, okay? So let's proceed with question number 32. This is still covering mood disorder. At least right now you will be able to know, no? So a client is diagnosed with major depressive disorder, for instance. Which nursing diagnosis should a nurse assign to this client to address a behavioral symptoms of this disorder? So titingnan natin, no? Ano ang nursing diagnosis natin about this? A, altered communication related to feelings of worthlessness as evidenced by anhedonia. Anhedonia appears to the patient with the schizophrenia. Social isolation related to poor self-esteem as evidenced by secluding self in room, or altered thought processes related to hopelessness as evidenced by persecutory delusions, or altered nutrition, less than body requirements related to high anxiety as evidenced by anorexia. Again, the first thing in mind that we have to look into in dealing with patients with psychiatric disorder will be security. So the answer is actually B, social isolation related to poor self-esteem. Now, you know, when they are secluding themselves in the room, is very dangerous, particularly if the depression is actually on the severe side. A nursing diagnosis of social isolation relating to poor self-esteem as evidenced by secluding self in room addresses a behavioral symptom of major depressive disorder. A major depressive disorder is associated with so many cases of suicide all over the world, no? So other behavioral symptoms include psychomotor retardation, virtual non-existent communication, maintaining a fetal position. Maintaining a fetal position is a coping mechanism that is employed most of the time by people with severe depression. And of course, no personal hygiene and or grooming. So right now, if the person with clinical depression or severe depression cannot take care of themselves, cannot cope up, there is a tendency that they may develop schizophrenia. There is a danger, default. So what do we need here? Psychosocial integrity. All right. Question number 33. A nurse assesses a client suspected of having major depressive disorder. Which client's symptom would eliminate this diagnosis? Titingnan natin, no? So A, the client is disheveled and malodorous. B, the client refuses to interact with others. There is an indication of social isolation in this case. C, the client is unable to feel any pleasure. We call this as anhedonia. Or D, the client has maxed out charge cards and exhibits promiscuous behaviors. So promiscuity. This could be coping mechanisms that may be employed by people with depression. So what do we have here? The answer is D, no? So the nurse should assess the client who has maxed out credit cards. You know what is actually the meaning of this one? An exhibit promiscuous behavior. Wala nang pakialam sa mundo. Gastos na ng gastos. This is an indication that the patient is about to commit suicide already. So this is the thing. That's the first consideration that we have to look into, no? So imagine, gastos ng gastos na max out yung credit card niya. At wala na siyang pakialam. Kahit sino-sino na lang, pwede na, no? That's the meaning of promiscuous behavior. Now, according to DSM-5, that I give the link where you can download it. I hope you will read about this, no? These symptoms would rule out diagnosis of major depressive disorder. Right? Question number 34. A nurse reviews the laboratory data. This has something to do with physiology of the patient, no? With severe depression. So ano ang dapat nating tingnan? Ang question number 34. The nurse reviews the laboratory data of 29-year-old client suspected of having major depressive disorder. Anong laboratory value ang magro-rule out ng diagnosis? Okay? So anong ibig sabihin nito? Titingnan natin ano ang laboratory value na magko-confirm na ang condition ng pasyente ay hindi severe depression. Is it A, thyroid stimulating hormone level of 6.2, potassium level of 4.2 milliequivalent per liter, sodium level of 140 milliequivalent per liter, or calcium level of 9.5 milliequivalent deciliter. Usually, a patient with the abnormal TSH hormones may actually exhibit depression. So ito magro-roll out, no? So our answer would actually be A. According to Diagnostic Statistical Manual 5, symptoms of major depressive disorder cannot be due to the direct physiological effects of general medical conditions. Kaya nga, pati sa lahat ng, pati sa schizophrenia and inner psychotic disorders, dapat natin ma-rule out ang physiological causative agent. Kaya nga, ini-examine sila ng neurology if there is a damage on the nervous system, malamang yan, particularly if there is a brain injury, malamang yan, there is a problem with the behavior of the patient. So that must be ruled out. Kasi kahit na anong gawin natin psychiatric intervention, if the cause is by neurological factors, it's based on physiology, then sometimes it's actually very difficult, no? So it can be treated by neurologists, not psychiatrists. So that's the thing. In this case, it's very clear that the symptoms of depression are caused by abnormal TSH level. So therefore, the case of the patient will not fall under mood disorder, will not fall under clinical depression. So we can treat the patient's disorder by treating the prevailing condition, which is the abnormal level of TSH in the blood. That is the thing, no? So it's very tricky, but we have to look into that. So sometimes laboratory report is actually needed also. Lithium toxicity is actually going to be looked into most of the time also. Question number 35. A depressed client reports to a nurse a history of divorce, job loss, family estrangement, and cocaine abuse. So according to learning theory, what is the cause of this client's symptoms? No? Depression is a result of anger turned inward. See, usually it goes like that, no? As Sigmund Freud mentioned. All right. So depression is a result of abandonment. Depression is a result of repeated failures, or depression is a result of negative thinking. Now, depression usually is associated with repeated failures. So that's the thing, no? Imagine we keep on trying, but there is failure, right? Anyway, the answer is actually C. Learning theory describes model of learned helplessness in which multiple life failures cause the client to abandon future attempts to succeed. No? So the client need is psychological integrity. That is what we are addressing here. On are we going to continue? Can we have a 5-minute break? Ronald?
Yes,
Hello?
doctor, no problem.
Yeah, are you still with me?
Yes, doc, we are
Yes,
here.
Doc.
So I would like to have
Yes,
a
Doc.
break, no? 5 minutes break muna. Yung pusa ko, kinakaskas ang upuan ko, gustong kumain. Yep, I'm there. Okay na, may 14 questions na lang tayo. Okay? So the next question is question number 36. What is the priority reason for a nurse to perform a full physical health assessment on a client admitted with a diagnosis of major depressive disorder? So bakit natin kailangan ng full physical assessment sa pasyente? So A, The attention during the assessment is beneficial in decreasing social isolation. B, depression is a symptom of several medical conditions. Chances are yes. C, physical health complications are likely to arise from antidepressant therapy. Or D, depressed clients avoid addressing physical health and ignore medical problems. So what could be the answer in this case? Why do we need to address, why do we need to do physical health assessment complete at that? No? So the answer is B. Depression may actually be associated with several medical disorders, like I mentioned to you. So there is a problem with the thyroid stimulating hormones. There are other conditions that may actually give rise to diagnosis of depression. That's why we have to look into that when we have to eliminate the causative agent, so that we have to look into the real causative agent of the disorder. Medical conditions such as hormone disturbances, electrolyte disturbances, and nutritional deficiencies may produce symptoms of depression. So, pag may ganitong condition, i-address muna natin ang comorbidities nila bago nating i-address yung depression, no? These are a priority to identify and treat the patient, no? Since they may be the cause of the depressive symptoms and represent physiological needs. So always titingnan natin yan, no? Pati yung sa more evident cases sa psychosis, so eliminate din natin, as I mentioned earlier, kung may brain injury o wala. Kung may brain injury, kahit anong gawin natin treatment sa kanila using psychiatric treatments, wala talagang mangyayari sa pasyente. So we have to address immediately first the injury. So in this case, for severe depression also, the first thing that we have to do is to address other medical problems before we can address the depression of the patient. Kaya kinakailangan natin ng full medical assessment as that. So question number 37. A nurse admits an older client who is experiencing memory loss. Memory loss is a part of cognitive disorder. In memory loss, we have Alzheimer's diseases, among others, no? Confused thinking and apathy. So a psychiatrist suspects depression in this case. What is the rationale for performing a mini mental status exams? Usually we do that as nurses. So we are trained to do MMSE, no? Mini mental status examinations. So why is it that we are doing that? When you say, hey, there could be a depression, the psychiatrist mentioned, so we can conduct and utilize many mental health examinations to rule out bipolar disorder, or B, to rule out schizophrenia, or C, to rule out neurocognitive disorder, and D, to rule out personality disorder. Remember, ang psychiatrist nagsuspect ng depression. Pero nung inadmit natin ng pasyente, very old. As I mentioned earlier to you, is already an older client experiencing memory loss and confused thinking and apathy. So more or less, there could be a neurocognitive disorder, no? Because the first thing that I suspect when I read this question, it could be cognitive disorder. It could be Alzheimer's disease. But the doctor, psychiatrist, also speaks otherwise. So the doctor says there could be a depression. So there are two conflicting diagnoses in this case. So what do we eliminate? So we, of course, we have to eliminate neurocognitive disorder in that case. No? The patient who is old come to us, the doctor suspects that there is a depression. But since we know for a fact that his age and some very common symptoms presented during that admission process is a symptom of cognitive disorder, we have to eliminate that. So we have to conduct mini mental health examination. So a mini mental examination should be performed to rule out neurocognitive disorder. Titingnan natin kung may other conditions siya like Alzheimer's disease. Because the elderly are often misdiagnosed with neurocognitive disorders as ED. No? When depression is their actual diagnosis. All right? So memory loss, confused thinking, and apathy are also common symptoms of depression in the elderly. Alright. So, dapat eliminate natin yan. So, that's the reason why it's very important also that we nurses would actually know how to do differential diagnosis. Luckily for me, because I'm a psychologist also, so I can do differential diagnosis. I can eliminate immediately. But for nurses, we have to think that way also. Yun, tandaan natin, we are going to make differential diagnosis to eliminate one disorder as such so that we can focus on treating the specific disorder that the patient may actually. That's the reason why I keep on telling you, yung observation talaga ng pasyente may require 21 days continuously para ma-establish natin kung ano ang sakit talaga ng pasyente. Continuous monitoring. Continuous observations so that we can actually take note what type of disease that the patient may actually have. Moving on, question number 38. A client is admitted to the psychiatric unit with a diagnosis of major depressive disorder. The client is unable to concentrate, has no appetite, and is experiencing insomnia. It's very common among patients who do have clinical depression or major depressive disorder or major depression. These are all the same, which should be included in the client's plan of care. A, a simple structured daily schedule with limited choices of activities. B, a daily schedule filled with activities to promote socialization. A, flexible schedule that allows the client opportunities for decision making. Or is it D, a schedule that includes mandatory activities to decrease social isolation? You know, ang pasyente may severe depression, dapat ang i-stabilize natin muna ay yung activities of daily living. Dapat may schedule. Kaya ang sagot is letter A. No? Dapat i-schedule natin yan. May schedule. Ano ang gagawin mo sa paggising mo ng umaga? 9 o'clock, anong gagawin mo? 10 o'clock, ano ang gagawin mo? So that the patient may actually look forward to do those things para ma-eliminate nila ang thinking nila about unnecessary things. No? A client with depression has difficulty concentrating and may be overwhelmed by activity overload or the expectation of independent decision making. They cannot decide on their own. So they need to follow rules. So ang gagawin ng nurses would actually to make it sure that may schedule silang susundin. This is actually very crucial and very important. Halimbawa, na-admit sila sa hospital, so the same patient also, the same types of patients, we can actually do that. No? Anong gagawin nila dapat sa umaga? Anong gagawin nila dapat sa 10 o'clock, 12 o'clock? So they will be looking into that. No? A simple structured daily schedule with limited choices of activities is more appropriate. Hindi na natin sila dapat pag-isipin kung anong gagawin kasi hindi din sila nag-iisip. Hindi na sila makapag-isip. That's actually usually the problem with major depressive disorder. All right. Question number 39. An isolative client, patient who is isolated who would like to be alone, was admitted 4 days ago with a diagnosis of major depressive disorder. Which nursing statement would best motivate this client to attend a therapeutic group being held in the milieu? Therapeutic milieu, we are doing that. We'll go to the day room when you are ready for the group. But actually, itong napakagandang arrangement ng mental hospital dito sa UAE. May playroom sila, may day room sila, may smoke. Funny thing is they're allowed to smoke also. May smoking area din sila. So, napakaganda, no? So, what are we going to do? We'll go to the day room when you are ready for group. Or I'll walk with you to the day room. Group is about to start. Or it must be difficult for you to attend group when you feel so sad. Let me tell you about the benefits of attending this group. What are we going to do? How are we going to invite the patient? How are we going to say that? Invitation. So our answer should be, I'll walk with you to the day group. Right? The group is about to start. So a client diagnosed with major depressive disorder exhibits little to no motivation. Halos ayaw nilang gumawa. Halos ayaw nilang umalis sa kanilang bed. So the best way to convince with them is actually to assist them. No? they have no motivation at all and must be actively directed by staff to participate in therapy. Kaya in related question, my question earlier, kailangan talaga ng kanilang oras ay definite. So there is structured time. Pero kundi yung pasyente, maaaring hindi makihalo-bilo. Hindi gagawa yan kasi hindi sila nag-iisip kung anong gagawin niya. So it is difficult for a severely depressed client to make decisions. Hindi sila makapag-decide. And this function must be temporarily assumed by the staff. So you do the decision making for the patient. Sometimes they obligedly follow also. Okay? So that's what we are going to do with them. For question number 14. A client who is diagnosed with major depressive disorder asks the nurse what causes depression. Okay, how do you explain this? Which of these is the most accurate response to your patient? A, depression is caused by deficiency in neurotransmitters, including serotonin and norepinephrine. Obviously, it could be. B, the exact cause of depressive disorder is unknown. A number of things, including genetic, biochemical, and environmental influence is likely to play a role. Obviously, it could be the answer also. So depression is a learned state of helplessness caused by ineffective parenting. Of course, I will not say that to the patient. Or is it D, depression is caused by intrapersonal conflict between the id and the ego? Of course, I'm not going to tell that to the patient because the patient may not understand id and ego. So the best way when we are going to look to the patients that it could be the language that they need to understand. So the answer is B. Because the patient, if we're going to mention about letter A, the patient may not understand neurotransmitters, serotonin and norepinephrine. These are all neurotransmitters that can be found in the brain. So the best explanation that the patient may actually receive from us is a normal conversation. Like for instance, the exact cause of depressive disorder is no, and a number of things. So these are easily understood by the patient, no? So when we explain certain condition to the patient, we'll make it sure that our explanation are things that they can easily understand. Okay, so depression is likely an illness that has varied and multiple causative factors, but at present, the exact cause of depressive disorder is not entirely understood. And obviously, of course, with the way we communicate with the patient, we have to look into that. No, the explanation must be easily understood by them. So what we are addressing here, psychosocial integrity. Again, I'm reminding you, we are always looking into the 3 dimensions of mental health. Physiological, bordering to biological and physiological aspect, psychosocial, then psychological, then sociocultural. We have to look into that over and over again. Question number 41. This time, it will be a different story. Okay? So, it's personality disorder. All right. What do we have here? This is also very common, particularly under borderline personality disorder. I would like that you will understand about this also. I prepared 10 questions on personality disorder. And when you say personality disorder, is something wrong with your personality. And there are so many types of it. Okay? So let us try to understand what personality disorder is and try to answer the questions that I prepared for you. Maybe they will ask questions like this in the board examination. Maybe 3 to 5 questions. So the most common questions are looking into borderline personality disorder and antisocial personality disorder. So question number 41, let's try to look at this. Now, during an assessment interview, a client diagnosed with antisocial personality disorder speaks, curses, yung speech, dumura, nagmura, and refuses to answer questions and do not want to answer questions. Which is the most appropriate nursing statement to address this behavior of your client? A, are you going to be confrontational? You're very disrespectful. You need to learn to control yourself. Or B, I understand that you're angry, but this behavior will not be tolerated. Or is it C, what behaviors could you modify to improve the situation? Or D, what anti-personality disorder medications have helped you in the past? So how do you answer that?
right? How do you confront the patient? How do you talk to the patient that his behavior is not acceptable to you? See, remember antisocial personality disorder. We'll come into that later on. I'll prepare a short explanation about the different types of personality disorder that we may actually have to deal with when we become psychiatric nurses. So the answer is actually letter B. I understand that you're angry, but this behavior will not be tolerated. You see? So why? The appropriate nursing statement is to reflect the client's feeling while setting firm limits on behavior. We should need to set limit immediately, or else they will be controlling in the future. So clients diagnosed with antisocial personality disorder have a low tolerance for frustration, see themselves as victims always, and use projection as a primary ego defense mechanism. Everything that's happening to me is caused by others. That's the meaning of projection. No? We look at the problems that we have on others. So antidepressants and anxiolytics are used for symptoms relief only. However, there are no specific medications targeted for the treatment of personality disorder as such. So we are going to treat the patient based on the symptoms presented only. The most common medications that we give are antidepressants and anxiolytics. All right? So let us try to look into a personality disorder. What problems do we have in here? Now, if you're going to look into Sigmund Freud's theory of personality, every single individual, the personality is made up of three areas, three dimensions, three parts, three structures: id, ego, and superego. So there is always an interaction between the three. That's the reason why we call his theory a psychodynamic theory of personality, interacting together, right? The one that is actually on the executive mode is the ego. So the one that's actually staying on the other side will be the id and superego. When there is a dysfunctionality among the interactions of the three structures of personality, then there is a personality disorder, right? When the dynamic cannot be seen anymore, then there is a personality disorder. So personality can be defined as a matrix of enduring characteristics and attitudes of an individual that determine a person's adjustment to the environment. There are so many schools of thought that are explaining personality. As I mentioned to you, Sigmund Freud mentioned that personality could be developed at the age of 7 already. So the behaviors that you are displaying right now is the outcome of your growth from 0 to 7. Now, another school of thought that contradicts this is Erik Erikson. And the theory is called psychosocial theory of personality, wherein the personality actually is going to be developed throughout time. That means to say behaviors may change through time. That's a plausible explanations also. But most of the psychiatrists and clinical psychologists like me are looking towards the explanation of Sigmund Freud, psychodynamic perspective. No? Now, when the enduring characteristics and behaviors cause difficulties for self or to others around, the person can be said to be suffering from personality disorder. Ano ang nangyayari dito? The enduring characteristic and behavior cause difficulties. May problema na. You are becoming dysfunctional na. Halimbawa, antisocial personality disorder. Alam mo yung mga criminal, for instance, they think that they are victims. We are poor. I am poor. So I'm going to steal. So itong nagnanakaw na sila. Pumapatay na sila ng tao. They have no respect to the properties of others. They have no respect on the life of others. So, gagawa na lang sila ng kwan. Hindi sila pwedeng magsaya o mabuhay nang hindi nakakapanira sa iba. Hindi nakapagnakaw. So they are becoming dysfunctional. Yun. Kaya may personality disorder because of that. No? So the person can be said to be suffering from personality disorder. As I give to you a while ago, a very big example is antisocial personality disorder. Antisocial. Okay? They are against social. Okay? So the most common antisocial, the most people with antisocial personality disorders are the criminals. Very simple. No? They have no respect on the properties or life of others. These are the clinical features, no, of people with personality disorder. Patients with personality disorder have wide-ranging problems in personal, among themselves, the relationship to others, social, their work, occupational spheres. They cannot work. They cannot last long. When they are in the relationship, they can last in the relationship. They may be controlling also. They may be victims also. Or they think that they are victims also. That's why they may not maintain good relationship. Ito yung mga papalit-palit ng boyfriend, papalit-palit ng asawa, papalit-palit ng trabaho. May trabaho sila ngayon, next month wala na. Something like that. They cannot simply stay in one job. Yeah? So you may question yourself if you may have personality disorder. We'll try to look into the classifications later on. I'll just give you or prepared a simple explanation about this to address the other 9 questions that I prepared. No? These problems usually persist throughout adult life. So magmamanifest lang yan kung ikaw ay matanda na. Kasi nga, sinabi ko kanina, the personality of the person could have been fully developed at the age of 7, according to Sigmund Freud. So, nagmamanifest yan pag tumanda na. It's a long explanation looking into the different stages of psychosexual development by Sigmund Freud. We have to look into oral, anal, phallic, Latin, and genital. And in relation to that, with these structures of personality, it takes time to explain that, but I really would like you to look at this, no? So the personality disorders are divided in 3 clusters. Cluster A, B, and C. So titingnan natin ito kung ano ang meron sa cluster A as appeared in DSM-5 TR, right? So in cluster A consists of eccentric personality disorders. Center of attention is actually themselves. Cluster B consists of dramatic personality, like in the case of dependent personality disorder, yung mga taong nagsasabing, wag mo akong layuan, hindi ako mabubuhay nang wala ka. Something like that. They are very clinging. They are clingy, no? Or cluster C includes anxiety personality disorder. I'll give you some examples. Obviously, there is a problem with the way they grow, with the way they were nurtured. Obviously, there is, no? But we are not going into that. We have to address the disorder as such. What do we do as nurses when we see this kind of people that we have in our hospital? Cluster A, what do we have here? We have paranoid type, no? They are suspicious, guarded, unemotional, non-trusting, self-referential, over-concerned, with hidden meanings and motives, litigious. They are very judgmental. They are very suspicious. They don't trust others. They trust only themselves. Schizoid, on the other hand, walang pakiramdam, cold, aloof, asocial, indifferent to the feelings of others. Wala silang makiramdam, nasasaktan ng iba. Then schizotypal, magical thinking, they are always thinking about so many things, very grand. No? Self-preferential is about me, and me alone. No? According to me. Perceptual distortions, they do not want to see the reality. That's the reason why we call it schizotypal personality disorder. You see? Parang yung manifestations nito ay schizophrenia, but not schizophrenia. Odd communication patterns. And they would like to be self-isolated. They would like to be alone because no one actually will understand them, especially about dramatical thinking when they transmit it to other people. Right? On cluster B personality, what do we have here? The antisocial personality. So here, they are very irresponsible. They are against society. That's the meaning of it. No? Lack of concern for others. Not able to maintain relationships. So, papalit-palit ng boyfriend, papalit-palit ng asawa, papalit-palit ng trabaho. Okay? Often, criminals are classified as such. Violation of law, they violate the law, masaya sila pag nagbabiolate ng law. And the rights of others. That's the reason why they have no qualms when they kill other people. When they steal the properties of other people, masaya pa sila. And they are very aggressive. They are manipulative. And one thing more that is actually very common is that hindi sila maaring magsisi. Ay ano kung nasaktan kita? Ay ano kung napatay kita? Ay ano kung nagnakaw ako sa iyo? They lack remorse. So that's actually the problem that we have. No? For antisocial and the cluster B. The most common, this is not hospitalized, but we find them in jail. We can find them in jail. But for number 2, these are often hospitalized because we can often see symptoms. Borderline. There is identity diffusion. They may not understand who they are. Intense and unstable emotional relationships. Very impulsive, manipulative, and suicidal. Right? Yung magpapakamatay ako, pag, things like that. No, they're very suicidal. And the most common signs that we can actually is that they are actually directing injury towards themselves. Yung naggaganon-ganon sa sarili nila or nagpo-pull out ng hair, right? They are definitely hurting themselves. Ito namang histrionic, ito yung mga taong gusto maging center of attention. No? They really would like to be the center of attention. They are very flamboyant. Yung naninilaw na, lumalabas sila sa bahay, parang may parang may hepatitis sila kasi lahat ng ginto nila, binibigay nila, inilaladlad nila. Naka-lips, kung todo lipstick, kung todo purloloy. No? These are very flamboyant. No? So they are very dramatic. Likewise, they seek attention. They really would like to be the center of attention. Me, and me alone. They really would like to be admired by everyone. They are vain and they are demanding. Okay? So ito also is, histrionic. It's okay lang naman, pero very annoying sometimes, no, when you see people like that. And narcissistic, these are the people who are very grandiose. It comes from the Greek mythology, no? Pangalan ng Narcissus, no? Tinignan niya yung kanyang sarili sa balon and he fell in love with himself. So that's actually the meaning of narcissistic personality disorder. He loved himself and himself alone. Very grandiose. Napakagwapo niya, napakaganda niya, napakayaman niya, no? And he has continuous need for admiration and to be center of attention. Lack of empathy. Walang pakialam. Ang pakialam niya is about sarili niya. Basta mahal ko sarili ko, hindi ko mahal ang iba. That is actually very common among people who do have narcissistic personality disorder. And then for cluster C, dependent, no? Very clingy. Ito yung mga taong very submissive, very clinging, unable to make decisions. Pinapaubayan nila yung decisions sa iba. Halimbawa, yung mga taong yung may asawa, hiwalay ng asawa, ayaw magpaghiwalay. O yung mag-boyfriend, ayaw humiwalay, then hindi ako mabubuhay ng wala ka. They are in continuous need of others, excessive need to be cared by other people. Kaya nga we call it dependent personality disorder. Ano cluster C? Avoidant naman, ito yung really would like to be, they are trying to avoid people. Boss, for instance. They desire for affection and to be in relationship, but sensitive. Very, very sensitive, and they do not want to be hurt. They are fearful of rejection. That's the reason why they do not want to relate with other people. They do not want to see their boss because they have low self-esteem also. Yeah. Then obsessive compulsive, under personality disorder, the most common person that displays this is Mr. Beans, if you know that. No. So perfectionist, obstinate, parsimonious, pedantic, indecisive, over-concerned with laws. No, the unconscious, the conscience is actually taking over. They are always looking into rules and morals. You cannot do this, you cannot do that. Bawal yan, bawal ito. And they are unable to relax because they are on lookout of following everything. Following the right and wrong, the blue and white, things like that. They can go outside the box. And then passive-aggressive. This is different from what we are actually talking about in anxiety disorder as manifested by obsession and compulsion wherein they are actually needing ritualistic behaviors. Anyway, we have also passive-aggressive. These are resistant to demands, stubborn, procrastination, intentional forgetfulness, and efficiency. They are aggressive but they do not want to show. Like for instance, the basic common is this, the basic example is this, no? Halimbawa, ikaw ay nag-prepare ng pagkain, ikaw ay waiter, no? yung nag-order sa'yo ay very rude. Ang gagawin mo, mag-prepare ka ng pagkain at dinuraan mo yung pagkain. Siyempre, hindi niya malalaman. Pero sa isip mo, nakaganti ka. No? That is a manifestation of passive-aggressive personality disorder. So, these are people who may actually live among us that they don't need hospitalization. They are still functional in any way. No? But sometimes they are very uncomfortable to live. That's the reason why it becomes disorder, because most of their manifestations are always interfering with their functionality. That means to say, sometimes their activities of daily living are compromised or affected. Okay, so we do not encounter them in the hospital. The most common hospitalized patients with personality disorder, as I mentioned, is under cluster B, borderline personality disorder, because they have the capacity to injure themselves and others. They have often suicidal ideation. Here we call it suicidal threats. Yeah, so kaya na hospital sila. And when we treat them, it's like they have. We treat them with antidepressant. We treat them with lithium carbonate. So that's the reason why lumulobo sila palagi, no? So yun ang sinasabi ko sa iyo kanina ng pasyente, no? So lulubo sila, dodoble yung size ng kanilang katawan. But the rest, they are living among us. They are living with us normally also. Right? So in question number 42, what do we have here, no? A client diagnosed, 8 questions na lang. A client diagnosed with antisocial personality disorder comes to a nurse's station at 11 p.m. in the evening, requesting to phone a lawyer to discuss filing for a divorce. Imagine, 11 o'clock in the evening. The unit rules state that no phone calls are permitted after 10 p.m. Which nursing reply is most appropriate? Go ahead and use the phone. I know this pending divorce is stressful. Or B, you know better than to break the rules. I'm surprised at you. Or C, it is after 10 p.m. phone curfew. You will be able to call tomorrow. See, the decision to divorce should not be considered until you have had a good night's sleep. Of course, you know the answer. It's very obvious. The answer is C. No? So it's after 10 p.m. You should actually, now the way we deal with patients, that we have to be soft but firm. So we have always to lay down the rules and regulations that we have in the hospital. We have to be very, very soft but firm, compassionate but firm. That is what we need to do when we are going to communicate with our patients. Now, that's the basic role of nurse-patient relationship, therapeutic communication. The most appropriate response by the staff is to restate the unit rules in a calm, assertive manner, but do not challenge the patient. Now, because of the probability of manipulative behavior in this client population, it is imperative to maintain that the rule will be very consistent. We apply the rule to everyone, to anyone in the world. Question number 43. A client diagnosed with paranoid personality disorder becomes violent on a unit. Okay? Which nursing intervention is most appropriate? Paranoid personality disorder, they are shouting and so on and so forth. They are agitated. So what do we do? Again, patient, we are looking forward towards the security of the patient and others. Provide objective evidence that violence is unwarranted, or initial restraint to client to maintain safety. Use clear calm statement and confident physical stance, or empathize with the client's paranoid perception. A and B will be eliminated. The possible answer will be and C, and the nearest answer is C. The most appropriate nursing intervention is to use clear, calm statement and to assume a confident physical stance, as always. No? A calm attitude from the nurse avoids escalating the aggressive behavior of the patient. Usually, the patient may be disarmed when we are very calm and very firm. So that we need to do all the time. If you're a trained psychiatric nurse, you do this all the time. No is no. Yes is yes. If you promise something, you have to give. I believe your teachers, when you were in your base in courses, were telling you that. No, you give what you promise. You mean yes if you said yes. You mean no if you said no. That's how we deal with psychiatric patients. A highly emotional client perceives an outpatient clinic appointment wearing flamboyant attire, that is not appropriate for the time being, spike heels and theatrical makeup. What do you think is the personality disorder that a nurse associate with this assessment? What do you think? No, a patient coming to you during the appointment in outpatient department with flamboyant attire. Obviously, it's very easy, no? What is this type of personality disorder? No, it's not convulsive, it's not schizotypal, it's not manic. It should be histrionic personality disorder, right? So the nurse is actually histrionic personality disorder with this assessment data, no? They really would like to become center of attention, very flamboyant. The most common thing that they have to do is to wear excessive makeup and excessive jewelries. They also wear their massive bling bling, no, and so on. Question number 45. A client diagnosed with borderline personality disorder brings up a conflict with the staff in a community meeting and develops a following of clients who unreasonably demand modification of unit rules. There is a rebellion inside the ward. How can the nursing staff best handle this situation? Allow the clients to apply the democratic process when developing unit rules? Obviously, no. In the ward, it is always autocratic. Maintain consistency of care by open communication to avoid staff manipulation, possibly. Allow the client spokesperson to verbalize concerns during unit staff meeting. May do. Maintain unit order by application of autocratic leadership. The answer is B. The nursing staff can best handle this situation by maintaining consistency of care. Always, whether we like it or not, the voices of the patient may not be heard. But of course, we have to follow patient's rights. But the only thing that is actually very important here is that we are going to be very consistent in implementing the rules and regulations that the patient may actually know. All right? So 46. Which adult client should a nurse identify as exhibiting the characteristics of DPD, dependent personality disorder, very clingy? We have to look at this condition. A physically healthy client who is dependent on meeting social needs by contract with 5-15 cats, or a physically healthy client who has history of depending on intense relationship to meet basic needs, possibly. A physically healthy client who lives with parents and relies on public transportation, no. A physically healthy client who is serious, inflexible, perfectionistic, and depends on rules to provide security. The answer is C, all right? A physically healthy client who lives with parents and relies on public transportation, among others, no? So question number 47. A pessimistic client expresses low self-worth, has much difficulty making decisions, avoids positions of responsibility, and has behavioral patterns of suffering in silence, which underlying cause of this client's personality disorder should a nurse recognize. Nurturance was provided from many sources, and independent behaviors were encouraged. Nurturance was provided exclusively from one source, and independent behaviors were discouraged. Nurturance was provided exclusively from one source, and independent behaviors were discouraged. Or nurturance was provided from many sources, and independent behaviors were discouraged. Now, in taste taking, titingnan natin yung mga similarities of the sentences. Very tricky yan. One word may actually mean a correct score or not. Okay? So the answer should be actually be nurturance provided from one source and discouragement of independent behaviors can attribute to the etiology of dependent personality disorder. Dependent behavior may be rewarded by a parent who is overprotective and discourages autonomy. This is usually how we are nurturing our children, you know. So it has something to do with nurturance somehow. So family members of a client asked a nurse to explain the difference between schizoid and avoidant personality disorders. Which is the appropriate nursing reply that you may actually tell your client? Clients diagnosed with avoidant personality disorder desire intimacy but fear it, and clients diagnosed with schizoid personality disorder prefer to be alone. Clients diagnosed with schizoid personality disorder exhibit odd, bizarre, and eccentric behavior, whereas clients diagnosed with avoidant personality disorder do not. Clients diagnosed with avoidant personality disorder are eccentric, as I mentioned earlier, and clients diagnosed with schizoid personality disorder are dull and vacant. Clients diagnosed with schizoid personality disorder have a history of psychotic thought processes, whereas clients diagnosed with avoidant personality disorder remain based in reality. The answer is A. So the nurse should educate the family that clients diagnosed with avoidant personality disorder desire intimacy, but afraid of it. Yun lang yun. Gusto nila talaga makipagrelasyon, pero ayaw nila ng rejection. Yun ang problema sa avoidant personality disorder. Gusto nilang may kipagkaibigan, but ayaw nilang ma-reject ng kinakaibigan nila. That is usually the problem. Okay? In question number 49, that's somehow easy. Which nursing diagnosis should be prioritized when providing care to a client diagnosed with paranoid personality disorder? Again, paranoid. Pag nasa isip natin ng paranoid, they are very violent, so there is a danger among themselves and toward others. So risk for violence directed towards others, related to suspicious thoughts. I think that's the first thing in mind. Risk for suicide related to altered thought. No? Roll out that one. Altered sensory perception related to increased levels of anxiety, or social isolation related to inability to relate to others. No? Obviously, the answer is A. The moment that you come across paranoid, they are very violent already. So safety must always be looked into. No? Safety of other people and safety of the patient themselves. That's how it goes. And the last question is, a nurse tells the client that the nursing staff will start alternating within shift. No? Which response should a nurse identify as characteristics of client diagnosed with OCD, personality disorder? You really don't have to go to by that schedule. I would just stay home sick. There has to get a hidden agenda behind this schedule change. Who do you think you are? I expect to interact with the same nurse every Saturday. Sometimes the patients are actually very clingy. Also, they own you. So you can make these kids kinds of changes. It's not a rule that governs this decision. The answer is actually D. They're always looking for a rule, no? So the nurse should identify that the client diagnosed with obsessive compulsive personality disorder would have difficult time accepting change. So this is usually the thing that you will encounter. Tandaan natin, ang decision-making process natin ay usually associated with how we are going to make the patients safe. So itong more or less 5 slides that I will be presenting will be very important for our decision-making process in assuming the role of a psychiatric nurse if we're going to deal with them. No? Sa board examinations, dapat nating maintindihan ito. No? So psychiatric nursing is an interpersonal process that promotes and maintains the integrated adaptive functioning of patients. Always, we have to maintain interrelationship with the patient. Yun ang importante. So makikipagrelasyon tayo sa pasyente. Ang relasyon na to ay tinatawag na therapeutic relationship. The nurse works with other members of the treating team. We are a member of psychiatric team. We will not be alone. There will be doctors, there will be psychologists, there will be social workers, there will be a pathologist. There are so many workers that are actually involving in the treatment of psychiatric cases. We are a member of the team. No? And our basic roles will be to care, the first one, deliver care, to communicate, and to manage the care of the patient. This is extended towards the following basic role that we assume. I think I do not need to discuss, but I really would like to remind you about this. As a caregiver, that's the first. No, we are caregiver first, among others. Then we become educator, counselor, advocate, coordinator, and health promoters. So I do not need to discuss about that. And I believe I really would like to remind you about the basic role that we have as nurses. We do not just actually do a caregiver role. We do everything in this case. If we are going to be a nurse, and much more psychiatric nurses. And the basic tool that we will be using will be the nurse-patient relationship, or the NPR, as proposed by Hildegard Piplau. This relationship will form the basis of both psychiatric nursing treatment approaches, no? That will define loosely our therapeutic relationship. So as such, how do we actually do therapeutic relationship as prescribed by Piplau? There are 3, others there are actually 4, no? We actually do orientation phase because it's very difficult, whether we like it or not, that when we are going to go to the patient, we have to gain their trust first. That is the first thing that we have to achieve in the orientation phase. Mahirap kumuha ng mga information sa pasyente pag hindi natin nakukuha ang trust. So, ito sa orientation phase natin may establish ang trust. Then after nakuha na natin ang loob ng pasyente, we can actually do whatever we want to do using therapeutic interventions in the working phase. Then lastly, there will be a discontinuance of our service with the patient. So there is a termination phase that we need to end the relationship with our patient. We have to build contract in the orientation phase. We have also to terminate our contract with the patient properly, and obviously, of course, necessary. So these are some of the things that we are actually doing. So as nurses, we should always be consistent. We should always be positive in our attitude. We need always to actively listen. Like we psychologists, the first thing that we have to do is to listen. We close our mouth and we listen. Then as patient, as nurses, we have to set the pacing. We do not let the patient control the pacing. It will be, and of course, we need to control as nurses, no? So for the patient factors, they must trust us and they must always actively participate in their treatment, no? There are things that are hindering our therapeutic relationship, no? We are very inconsistent. Today we allow, tomorrow we don't. We are unavailable, we do have negative attitude, we always reject, and we lack confidentiality. So for the patients also, they may resist, they may not give the trust immediately, and of course, illness factors, no? When the patient may not necessarily actually communicate with you or ready to form relationship with you, that will be a very big problem in psychiatric world. So with that, I would like to end my lecture, but I would like to emphasize this, no? Ang unahin natin, dapat ang treatment consideration natin sa pasyente na may mental disorder ay yung safety and security as always. No other else. If in doubt, you select always the choice on safety and security of the patient and others. Yun ang tamang sagot pag may question ako. Anong dapat natin gawin sa pasyenteng may mental disorder? Ganun yan. Alright? So, I think 3 hours, 3 hours lectures, no? Like doing in the graduate school. Any questions so far? So I really would like to discuss more because there are plenty. But I think I was given only 2 days to finish psychiatric nursing, so I try to maximize my time as much as possible to help you out. Hopefully, you will actually pass in the board examination. When in doubt, answer. That's the thing. Do not leave any question blank. Right? Trust your instinct. Trust your gut. Okay? Ronald, are you there? So,
Thank you so much for the time that you spent with our aspirants. So I hope all of them have gained and absorbed all those disorders, topics that you have been discussed today and from yesterday, I guess. So thank you, Dr. Guys. Virtual round of applause to Dr. Arnel.
Thank you so much. Thank you so much. No? Thank you.
Thank you.
Yeah, I'm happy to help you. Yeah.
Yeah. Anyway, Doctor,
Thank you,
you have another schedule for your for the theoretical foundations of nursing.
Oh.
Yeah, I guess it's the 3rd week of March. That one.
Yeah, let's see about it. Okay.
Yes.
No problem.
Okay. Thank you.
Okay. Have a good day. Bye-bye.
Okay. Bye bye to all.
Thank you, Doc. Bye.